was given analgesics, then other topical steroids, and all this were going on at that point of time. So prevalent had to stop. Atoset was given. Yes. So his routine examination, his hemoglobin was slightly on the lower side, ESR was slightly high, creatinine 1.32, albumin is slightly on the lower side, calcium 9.5, chest X-ray was normal. So his NCBs suggested prolonged digital latencies, then temporal dispersions, and reduced symptom amplitude. So there was suggestion of chronic demyelinating and axonal. Demyelinating and axonal type of sensorimotor polyradicular neuropathy, including all four limbs. So CIDP was the diagnosis. Now, chronic inflammatory demyelinating polyradicular neuropathy as far as our nerve conduction report. So, and along with the history, with 6-month history, progressive weakness or weakness of the proximal muscles more than distal, and that is most important is the rashes with the painful limbs. Now, prevalence of CIDP is 1 to 2 per lakh population. CIDP is more than 10 times commoner in diabetics than non-diabetics. These patients usually respond well to immunomodulator therapy, from corticosteroids to plasmapheresis to IVIG. These are usually the mode of therapies. In this patient, because of those painful limbs, the rashes, painful limbs, and considering the CIDP, and he was not really ready to get admitted and was not in a position to receive the immunomodulator therapies, we have started him on oral prednisolone. And improvement is anticipated in 3 months. So slowly we are expecting some improvement with steroids. But the incidence of CIDP is higher in diabetes. It is important to remember that CIDP is a syndrome. Though it was a diagnosis at that point of time, it's a syndrome, and other causes of CIDP has to be evaluated. So chest X-ray ultrasound was done, routine investigation was done, serology was done, hepatitis B, C, and HIV 1 and 2, which are again the causes of CIDP. Then chest X-ray ultrasound didn't show anything. We need to rule out paraproteinemia as paraneoplastic. CRP, ANA, vasculitic profile was done. Anti-DSDNA, we need to rule out SLE. RF factor, ANA, CRP was done. And serum protein electrophoresis was ordered. Serology was negative. CRP, ANA, RF factor, anti-DSDNA, vasculitic panel were not significant. Serum protein electrophoresis showed abnormal spike protein, it was more than 1.5 gram per deciliter. And there was high beta-2 microglobulin. Beta-2 microglobulin is another protein which is secreted by abnormal plasma cells, other than abnormal M-spike M protein. So, again, in this case, referred to hematologist, bone marrow aspiration was done, and this was a confirmed diagnosis was multiple myeloma. So, from diabetic polyneuropathy to CIDP, and then CIDP turned out to be, the cause turned out to be multiple myeloma. Then the last case. This is a 61 years old male, known diabetic for 8 years, presented to history of tingling and numbness of extremities, lower limb more than upper limb for last 2 years. He complained of severe burning feet. Again, burning feet, which kept him awake at night for last 6 months. He was complaining of feeling of imbalance or chakra sensation, as they say, while on sudden standing. So from here, there's severe painful neuropathy from history with imbalance while standing. There is a possibility of postural hypotension. He had also history of easy fatigability and recent loss of weight. He complains of irregular bowel habits, alternating constipation and diarrhea, and also sexual dysfunction. No history of toxins exposure or no history of recent fever. A general examination was normal. Lymph nodes were not palpable. Neurological examination shows loss of pain and thermal sensation distally. Areflexia, power was normal, and plantar downgoing bilaterally. Here it was again suggestive of there was bilateral superficial peroneal SNFs remain non-recordable. Soleus H reflex is non-recordable. So such axonal type of sensory motor motor neuropathy, sensory involvement was more than motor in this particular case. So along with left-sided radiculopathy also. So here this sural nerve is not clearly visible, not recordable. Peroneal, this is reduced peroneal motor response, which is not recordable, and reduced sural sensory response, which is not recordable there. And the absence is a sympathetic response suggestive of small fiber neuropathy. So SSR was positive, so there was small fiber suggestive of small fiber neuropathy. It's not, SSR was not recordable. So from history and examination, with the background of diabetes, painful neuropathy in the background of diabetes, so painful sensory neuropathy with autonomic features. Now next what? Differential diagnosis of sensory plus autonomic neuropathy. Diabetes obviously is the most common cause. Then comes amyloid neuropathy, vasculitic neuropathy, paraneoplastic sensory neuropathy, HIV-associated distal sensory neuropathy. These are the common differential diagnosis for sensory neuropathy with autonomic features. Diabetes was well controlled. HbA1c was quite 6.2. ACR 580, that means there was increased proteinuria. Creatinine slightly raised. Blood normal, vitamins normal, serology all FBFC and HbA1 and 2 normal. CRP, ANA, RF factor, DSD normal. Chest X-ray normal, and ultrasound showed get to fatty liver. Serum protein electrophoresis was also normal in this patient. So next, within next 2 months, his pain has increased manifold, and he found it more difficult to stand and walk. And on 2 occasions, he fall down in washroom after defecation. So while standing, while defecation, there was fall on 2 occasions. So there was progression of autonomic symptoms in last 2 months. And his standing and lying BP was measured. Lying BP was 140/90, while standing BP was 80/50. There's a significant drop of both standing and lying BP, and which amounts to severe postural hypotension. So again, painful sensory neuropathy with severe autonomic dysfunction. Wow. So he was put on fludrocortisone, and symptomatically he somewhat was relieved. His autonomic features somewhat relieved. And the patient was subject to skin and sural nerve biopsy and was later diagnosed as amyloidosis. So, key clinical points. What are the take-home messages for these 3 cases? So, it's not points, it's the only point which we need to think about. Is diabetic neuropathy is a diagnosis of exclusion. Just because someone is having diabetes and comes to us with painful limbs or tingling and numbness of limbs, I will just not conclude it as diabetic neuropathy. We should also think about the other causes. Thank you all. Thank you all.
Thank you, Dr. Jaydeep, for excellent talk and illustrative cases. My first question in case 1, you mentioned leprosy as diagnosis. What was the finding of nerve thickness and skin lesion? Because leprosy is widely diagnosed clinically and need not to take biopsy.
So I think those slides
patches was there.
Just jumped.
And it's nerve thickening.
Slide down, bro. Slide go down. Yes, those 2 slides, I think it will jump because of this. Slide start further.
There must be some scheme.
Yeah. Those slides were, when I was thinking slides, again, it was missed out. I'll tell you that. So that. Yes. So there were patching sensors for the bilateral and bilateral. Yes. Okay. Then I'll show you. Routine investigations done. That was okay. Yes, this is the slide which is missed out. So there was multiple skin, it was, I mean, jumped out. Yeah. There's multiple skin colored, for the right point.
And
Multiple skin colored hypopigmented fleshy papules and plaques over bilateral hands, abdomen, back and back of right ear. Yes.
thickening was there.
Yes, bilateral ulnar nerve and dead coronal nerve, common peroneal nerve thickening was there.
Yes.
Lymph nodes were not palpable. Eye and fundus examination was normal. So for, I mean, the problem was with this particular patient, the lesions, see the upper two, one dermatologist said that this is Hansen's, and the lower one, someone said this is sarcoidosis. So there was a conflict, confusion whether it is sarcoidosis, and it was diagnosed as cutaneous sarcoidosis, was the first diagnosis. The second diagnosis was Hansen's. So on the first go, we need to do, we have done angiotensin converting engine. That came out to be high, but still there was some doubts. Still, it was looking like Hansen's. So we had to, we have finally had to think about the nerve biopsy. So
Okay, and that in third case,
this picture in the same patient. This picture, someone was suggesting this is Hansen's, and in that picture, that is someone. Some dermatologists said it maybe possibly it could be sarcoidosis. And when the S became high, so most of the waiting for sarcoidosis.
without chest abnormal chest X-ray, it is unlikely to diagnose sarcoidosis.
Right.
There must be some finding in chest.
No, there was no chest finding. That's what I mentioned. The lymph nodes were not palpable, chest X-ray was normal. So cutaneous sarcoidosis was one differential diagnosis. But finally, when we, finally, ultimately, it is the skin on our
In
back.
third case, you diagnose amyloidosis. In amyloidosis, you must get some paraprotein or some abnormal protein electrophoresis. That was absolutely normal. How can you explain
that case? Right.
How can you explain?
Protein in that particular case was not.
What's the protein?
Usually paraprotein, M protein remains abnormal when you go think about amyloidosis, but in particular case, serum electrophoresis was normal. But because of severe sensory neuropathy, painful neuropathy, you had to finally have to go for this. Yeah.
Amyloidosis is a common cause for
yes.
autonomic neuropathy.
Right.
Actually, we have in Harrison neurology, I remember that if somebody is having sensory neuropathy with prominent autonomic symptoms and and we are not suspecting diabetic neuropathy, then the first thing should come in mind is amyloid. So that's real. Actually, my question is very plain and simple, just to incite my audience here for asking you more questions. If somebody is having diabetes and then he is coming with symptoms of, say, for example, tingling, numbness, and you are suspecting some neuropathic, that's suggestive of neuropathy. As you said, diabetic neuropathy is a diagnosis of exclusion. So clinically, what are the red flags that you'd expect in this setting that somebody is having diabetes and we are not thinking in terms of diabetic neuropathy? So what are actually the red flags for leveling it as diabetic neuropathy?
What the reflex?
Clinical was.
Clinically.
Yes.
See, diabetic neuropathy, mostly, polyneuropathy, usually symmetrical. Most commonly, it is symmetrical. Mononeuropathies can also be there, cadmium neuropathies can be there, but mostly symmetrical. And though amyotrophy is also explained in diabetes, but when there is diabetic neuropathy with proximal weakness more than distal, if such situation arises, then we need to think that something other pathology may be underplaying there. So
Question from the audience, please.
Usually in most of the diabetes practitioners, we keep on watching symptoms of sensory, motor and other neuropathies. But autonomic neuropathy is actually we must keep in mind. Most of the patients, they come with autonomic symptoms like GI related, bladder related, or sometimes cardiovascular also. So at least few clinical examinations like pulse variability, BP variability, postural
yes,
hypertension are small clinical tips to every diabetic patients, at least
Right.
for 5 to 10 years of duration or more than that. Even if without sensory motor symptoms, also many times autonomic neuropathy is present in some diabetic patients. So that should be in clinical
Absolutely.
or every clinician's mind.
heart rate variability, Valsalva, and
At least
blood,
that
blood
can be
pressure
done
standing
with
in
the
line.
chamber
It's
very
must.
well, only 2
Yes,
to 3
you
minutes. that
need
is
to examine in all
But
patients.
that happens in most of the times clinicians are always busy and we focus our mind mostly on the medical part and the treatment and all. And these things usually goes unnoticed.
Right. I mean, autonomic features
Yes,
often remains
basically
unnoticed.
doing a cardiac autonomic neuropathy test and other autonomic neuropathy test is very really difficult. And many times these are done only in research-based hospitals. Clinically, most of the time, scan and other things are not done.
Right.
So a simple clinical pulse variability, BP variability, or respiratory variability, and other things.
Right.
And as for few symptoms like autonomic bladder involvement or GI involvement. These few things will at least exclude clinical.
From history and with little bit of examination can.
Though
actually
there is
guide
nothing
us.
much to do. Yes, once autonomic neuropathy gets established, there is not much of that treatment other than controlling glycemic status and all. Thank you.
Is there any role of pregabalin other from symptom relief? And the prescriptions are going on pregabalin and vitamin B12 getting for years together. What is the
See,
reason?
there is
rational reason?
no role of giving, there is no scientific reason to give vitamins along with pregabalin. Pregabalin do have a role in the pain relief, I mean, symptomatic relief. And it has also, along with that, it has a side effect of, I mean, sleepiness. So it helps in reducing the pain. That's it. And topiramate has shown to, I mean, helping some kind of nerve fiber regeneration. Others, pregabalin, I have not seen, it's not been suggested. Methylcobalamin is not, yes, vitamin deficiency is not random and it is not the usual cause of neuropathy. Never. Yes. Randomly produced. Right. Unless there is severe deficiency of vitamins, I mean, neuropathy usually do not occur that way.
Thank you, sir. Thank you, Dr. Jadip, sir, for this wonderful presentation. I'm sorry, sir. Please continue.
All diabetic patients are taking usually first drug is metformin. Metformin is known to cause vitamin B12 deficiency. This is very important and you must check vitamin B12 level.
Right.
Sir,
This is very important.
metformin will only
That
cause,
may be the cause of neuropathy and not the diabetes.
sir, metformin only causes vitamin B12 deficiency after prolonged use. Prolonged continuous use at high doses has been seen to be associated with vitamin B12 deficiency. If it's a non-vegetarian patient, then as such, if it's been 5 or 6 or 7, 8 years of use, we are not concerned. In vegetarian persons, of course, there is an underlying vitamin B12 deficiency. There, with the addition of metformin, things are exaggerated. But generally, we've been using metformin for so long in so many patients, we do not see rampant vitamin B12 deficiency. Isn't it? Yes, indeed.
If there is no question, then I conclude the session. And we move for the next talk.
Thank you.
Thank you, sir.
And
Thank you,
about-
Dr. Jadip, sir, for this wonderful
Thank you all.
deliberation and resolving all the queries. I would request Dr. M. Prasad, sir, to felicitate Dr. Jadip, sir. Now I would request Dr. Joydip De sir to felicitate Dr. M. Prasad sir and Dr. Shyam Prakash sir. Thank you, sir. Thank you so much. Our next scientific session will be a debate, and the topic is insulin is the only safe option in treatment of gestational diabetes mellitus. We have Dr. Sandeep Kumar Sengupta and Dr. Bishwajit De sir as a chairperson. And for the motion, we have Dr. Smita Das Ghosh ma'am, and against the motion, we have Dr. Shankar Sen sir. We have Dr. Sandeep Kumar Sengupta sir and Dr. Bishwajit De sir as a chairperson. Dr. Sandeep Kumar Sengupta is the Dean of Student Affairs, North Bengal Medical College, and Assistant Professor of Department of Gynecology in North Bengal Medical College. And we have Dr. Bishwajit De sir. Dr. Bishwajit De is a senior consultant gynecologist with experience of more than 30 years and attached with Medica North Bengal, Siliguri. So, and I would like to request Dr. Smita Das Ghosh ma'am and Dr. Shankar Sen sir to please come up on the stage.
Welcome, and it's a very good evening to all. Sorry, I have a problem with the throats. But today we are in the battle between our gynecologist, Dr. Smita, and our physician, Dr. Shen. So I'm basically a gynecologist, but in this battle, I'm not taking any part of the gynecologist. So we are all waiting here to hear the debate between the gynecologist and the physician. So the dais is here. I request Dr. Smita. Yes. So I request all of us to wait for this beautiful debate session.
Good evening, everybody. We all know, particularly the male persons, they know that it's really very difficult to understand a lady. And when a lady walks in with diabetes and pregnancy, it becomes more difficult. So without wasting time, though there are so many debatable issues in management of GDM, but today's topic, the House feels the insulin is the only safe option in the treatment of gestational diabetes mellitus. That means diabetes detected first time during pregnancy. We are excluding type 2 diabetes mellitus in this debate. So before starting the top main part, how many of you in the House feel that insulin is the only safe option in treatment of GDM? Please raise your hand. Okay. Of course, you are excluded from this. So let me invite one of the brightest stars of this practice of this city, one of a brilliant student of RIMS, Dr. Smita Das Ghosh. Please put your case in front of us and let's see what happens. And as a rule, I must say that each the speakers will get 10 minutes of time to raise, to debate. And ultimately, as she is the first speaker and she is not getting an option to counter Dr. Shankara, and that is why she will get 2 minutes time for rebuttal. Okay, Smita, stage is yours.
Distinguished members of the House, my regards and a very good evening. I, Dr. Smita Das Ghosh, a practicing obstetrician, stand in favor of the motion, insulin is the only safe option in the treatment of gestational diabetes mellitus. Esteemed Council, I'm sure all of you have crossed busy roads bustling with speeding vehicles. And when you did that, did you run across the road like a frenzied loony, or did you cross the street cautiously, looking and listening for traffic? The fact that you're all alive and attending this debate today is proof that you indeed took the safe course of action. However, my honorable opponent here today has decided not to make the safe choice, and therefore over the next few minutes, I will be making desperate attempts to make Dr. Sen realize the utter iffy and plain fallacy of his stance. Gestational diabetes mellitus is the most frequent complication of pregnancy, affecting about 14% of all pregnancies. It contributes to about 10% of all sudden intrauterine fetal deaths and claims about 44% of all stillbirths. Therefore, it would be no exaggeration to say that indeed gestational diabetes mellitus is one of the worst petrifying ordeals for any obstetrician. Having said that, it would be wise to remember the words of William Osler in the treatment of such patients. He said, "It is more important to know what sort of a patient has a disease than to know what sort of a disease a patient has." Meaning, the pride of place in the treatment of gestational diabetes mellitus is not the pregnant diabetic mother, but the safety of the unborn fetus, the precious child in her womb. And may I here remind the opposition that the English Oxford Dictionary defines safe as protected from or not exposed to any danger or risk, not likely to be harmed or lost. Medicine is intention, and a good doctor must exercise good judgment and aim not just at treating the diabetic mother, but preventing diseases in her unborn child. Learned Council, you would all agree that in cases of minor blood glucose derangements, the first line of management, I repeat, management and not treatment, the first line of management in minor blood glucose derangements would be conservative. However, in the setting of persistently deranged blood glucose levels, the choice of a drug is guided by three clinical aspects. The first, effectiveness of the drug. Second, the safety profile of the drug in terms of the mother and the unborn fetus. And third, the swiftness of onset of action of the drug, as prompt control of blood sugars is vital, in fact critical, in preventing adverse pregnancy outcomes, especially preeclampsia, which directly contributes to 15% of all maternal deaths. Sudden intrauterine fetal deaths, hyperbilirubinemia, hyperviscosity syndrome, hypocalcemia, and of course, hypoglycemia in the newborn. All major textbooks and databases, including PubMed, Cochrane Library, Web of Knowledge, and clinical trial registries have upheld subcutaneous insulin therapy as the gold standard for the treatment of gestational diabetes mellitus. And in spite of this, my heroic opposition may be tempted to amuse himself with oral hypoglycemics. However, the studies on oral hypoglycemics, particularly metformin, are either case-controlled trials, observational studies, or RCTs with small sample size, lacking the power of confirmatory conclusions on relative risk and benefits of metformin. The side effects of metformin are difficult to ignore. First, lower gestational age at delivery, meaning preterm births. Second, lower average birth weights. And third, and most important, higher incidence of childhood obesity, which in turn leads to frank diabetes, hypertension, dyslipidemia, and depression in the future adult. Studies have proven that metformin easily crosses the placenta, and in fact, the umbilical cord blood levels of metformin are as high or even higher than simultaneous maternal levels. In fact, the MIT TOFU trial of 6 to 9-year-old offsprings exposed to metformin in the womb shows that these children are distinctly and statistically significantly heavier and obese with higher weight to height ratio and higher waist circumferences. Still, my opposition may try to dissuade you by inflating certain aspects of insulin. First, the higher risk of hypoglycemia. Well, we are all aware that the physiology of pregnancy necessitates frequent dose titration and dose modification depending on patient's diet, weight gain, and lifestyle. And this is not something that cannot be managed with a detailed guidance of dose and counseling. Second, increased maternal weight gain, which is certainly amenable to physical education, dietary modification, and medical nutrition therapy. And last but not the least, multiple daily injections, the pain of which is nothing compared to the pain of losing a child. Yet in extremis, my opposition may argue that in certain rural settings, patients may not be able to use insulin satisfactorily or effectively due to barriers such as language, comprehension, or cultural influences. Here I suggest that we do use the armamentarium of Ashas and Anganwadi workers who are supposed to help us deliver better antenatal care to mothers such as diabetic mothers. Last but not the least, in pregnancies affected with hypertension, preeclampsia, and intrauterine growth retardation, metformin cannot be used due to risk of growth restriction and acidosis in the setting of placental insufficiency. In all these cases, insulin remains the only safe option. Also, recently, the US Preventive Services Task Force reviewed in fact, several RCTs that provided better perinatal outcomes when treating gestational diabetes mellitus with lifestyle modifications and insulin. And they concluded that insulin is the first-line agent for the management of gestational diabetes mellitus and is much superior to any other oral agents, given the fact that these agents can cross the placenta and the long-term effects of these agents on the future offsprings are of great concern. August House, I do believe that our profession is in fact a calling that is a combination of both intellectual interest and moral duties. We cannot forget that a good doctor treats the disease, but the great doctor treats the patient with the disease. Thank you for your patient audience.
So we have had a beautiful talk about the use of insulin in gestational diabetic, the only insulin as Dr. by Smita. So I request our beloved Dr. Sankur Sen to debate about this use of only insulin in the diabetic. Dr. Sankur Sen, stage is yours. Kindly delight us.
My slides. Huh? Thank you, sir. Thank you, chairpersons. Thank you, Shandip. Thank you, sir. Always I should pay my regards to Rudraksh Superspeciality because they have given me this opportunity. Being a physician, I feel that we should have certain options. I agree with the topic in first attempt when Dr. Rundoti said to me that, will you agree to speak against the motion? I said, yes. Why I agreed? We all know insulin is the safest option. That I am saying in the first point. But is it the only safe option? Are the other options available? So my point of discussion today is not only debating. I am not going into direct personal attacks regarding the slides shown by me. I agree to each and everything. That is my first point. Second point, what I wanted to highlight is, today we all physicians, gynecologists, general practitioners, everyone who have gathered here, we should know what's latest in the armamentarium to fight gestational diabetes. So we should not be blind like the previous days when insulin was the only option or was, I agree it is the safest. That part I am not debating, but it's not the only safe option. So my point will be on, are there any role of oral anti-diabetic medications? Move hocche na re? So pregnancy, as you all know, is associated with changes in insulin sensitivity, and that may lead to changes in this blood glucose level, and prevalence of hyperglycemia during pregnancy have been steadily increasing with the rise of type 2 diabetes and obesity. And here also the insulin resistance comes into the picture. So the fight or the thing which the researchers are doing since long in diabetes is to find whether we can treat the insulin resistance part, because giving only insulin in patients are all against insulin resistance. But till date, this was the or is the only safest option. But what are the other options? That's my point of highlighting, and I will be successful if I can make my point. So I'm starting. I'll be skipping some slides in between, which has been discussed by my previous speaker. So the risk of adverse pregnancy outcomes definitely increases with diabetes. Now the diabetes in pregnancy, as you all know, it can be a pre-existing type 1 diabetic, a pre-existing type 2 diabetes, or only gestational diabetes. So we should first keep in mind the history. And you all know that gestational diabetes usually presents at around 24 to 28 weeks of gestation. And very importantly, the prevalence we have studies in 2015 in India, that West Bengal has around 11.6% prevalence of gestational diabetes. So it's a huge burden. And here we are looking for options other than insulin also. We all agree insulin is the safest option. Again, I am reiterating. Hey, battery is low. Charge level. আমার slide কি move করবে? So just until the slides are fixed, now the difference between pre-existing diabetes and gestational diabetes should come into the picture, because as you all know, the complications are already there in pre-existing diabetics, and these patients are usually in type 2 diabetes are highly insulin resistant, and they are most probably on multiple medications also, if not on insulin alone. And those medications usually include metformin, which we come across. And the complications should be taken, and other comorbidities are already there. And the outcomes also, like gestational diabetes, the outcomes are poorer with untreated or uncontrolled diabetes, type 2 diabetes. So the pregnancy is a diabetogenic thing. And very importantly, the insulin resistance, you can see in my first point, that is there, and the fat catabolism is there, decrease in muscle mass, energy to meet the maternal and the fetal needs, and accelerated starvation. So this is a diabetogenic state, and these placental hormones also influence it. So ultimately, this is not a disease of insulin deficiency in type 2 diabetes or gestational diabetes. The risk for the mothers, definitely it's there. So where we are treating, I'm not going into the details, but there are risks to the fetus also, large for gestational age, respiratory distress syndrome, neonatal jaundice, and all discussed by Dr. Smita. So diabetic embryopathy is a concept which is important because it influences organogenesis, fuel-mediated teratogenesis, exposure of metabolic fuel like glucose and ketone before 8 weeks of gestation, and the anthropometric and metabolic abnormalities then predominate. And it can lead to other risks like anencephaly, microbe. This is regarding the disease itself, not related to any medication in particular. So type 2 diabetes in a pregnant mother or a gestational diabetes mother are all having these risks, and this should be prevented. As William Osler said, that we should treat the mother first for the well-being of the child. I am also in the same boat as Dr. Smita. So preconception counseling, involvement, including folic acid, and all these are done by our obstetricians, and we are very happy when these patients come with all these things, because we have to treat diabetes. The target is like HbA1c should be less than 6.5. The evaluation of diabetes, whether the patient has complications, and these things come into the picture. So all diabetic women of childbearing potential should be educated regarding the risk from beginning, not at the end or when the patient is pregnant already. And very importantly, the retinopathy may worsen, the nephropathy may worsen if the patient is having pre-existing diabetes. So insulin is the first line of therapy. Again, I am reiterating, first line, definitely safe line also. If adequate blood glucose levels are not achieved during pregnancy with multiple daily insulin infusions, insulin pump therapy for safe treatment is also advised. So insulin we should be tried in different modes as well. We should treat the patients because we have to keep in mind about the effects of the pre-existing medications like ACE inhibitors, ARBs, atenolol, and statins. So ACE inhibitor, ARB, diuretics should be stopped. We have to start with CCBs, methyldopa, labetalol, alpha blockers, because along with diabetes, we have to control the blood pressure also. Because the maternal and neonatal morbidities will not only depend on diabetes alone. Statins and fibrates are needed to be discontinued. It's also a very risky situation of a highly atherogenic lady. So we should evaluate the thyroid function. So it's not only thing that insulin, titrate, keep the sugar under control and make your HbA1c your need target. And folic acid and all these things are very important. Now, when we screen, usually we diagnose if there are DIPSI guidelines. The 2-hour postprandial glucose of an oral glucose challenge test of 75 gram glucose is at 140. This is existing since 2006. Even a 1-hour PP blood glucose of less than 140, 2-hour PP less than 120, and fasting or pre-meal less than 95 should be our target. The management includes not only medical nutrition therapy and exercise, blood glucose monitoring, and intensive insulin therapy. And along with intensive insulin therapy, because of the insulin resistance, sometimes we need very higher doses of insulin, and sometimes they are inadequately controlled. So I am skipping these slides on medical nutrition therapy because these are also part of our management and these are quite safe. Along with insulin, walking is the best aerobic exercise and all. So what are the indications of pharmacotherapy? The fasting plasma glucose more than 95, 1-hour PP more than 140, and 2-hour PP more than 120. So the ADA, the American College of Obstetricians and Gynecologists, all have preferred insulin as the most important first-line therapy because it is the safest. Now, what should be an ideal oral anti-diabetic medication for us? And I am going to discuss and focus on 2 to 3 molecules where studies are going on and some studies are already been published. Oral drugs which should not cross the placenta. If it crosses the placenta, but it should not cause fetal hypoglycemia, hyperinsulinemia, and definitely it should not cause teratogenic effects even after crossing the placenta. The drugs which have been studied in pregnancy are metformin, glibenclamide or glyburide, the old name, and acarbose. So metformin, a sulfonylurea, and acarbose, that is an alpha glucosidase inhibitor.
Shankhoda, 2 minutes more.
Okay. So the guidelines say that there are certain molecules which we can use because the long-term safety data are still under research. Like glibenclamide came into the picture, and when glibenclamide was there, it has been found that umbilical cord plasma contained 50 to 70% of maternal levels. And glibenclamide gradually came out of the usage because of these findings, which was earlier found that among sulfonylureas, it was found to be comparatively safer. Similarly, the safety in pregnancy had been studied. There are various things, but the teratogenicity has not been well established. But the usage of glibenclamide along with insulin was something of problematic, which you all know, because this is a secretagogue and there are more chances of hypoglycemia even if we use it. Now, the next molecule is acarbose. You all know this is an alpha glucosidase inhibitor, which affects the post-meal glucose control. And it is and very importantly, there are certain studies, but the long-term safety data is scarce and till now not recommended. So my last point or last medication, or which we usually have the patients who are already on metformin, who are already being treated for polycystic ovary by our esteemed gynecologists. Ultimately, the metformin is very important. It's a category B drug. It's mentioned. It's not a category A. It's 10 to 15% crosses the placenta. And till date, there are certain studies and there are recommendations which say that its usage during second and third trimester after the 20 weeks of pregnancy is quite well established. And it was in 2020 guidelines came up in the NICE guidelines. And I have an article, I couldn't put it over here. The members of the FOXI, that is Federation of Obstetric Gynecologists of India, which my previous speaker might also be a member of, in March 2021, their endocrine guidelines said that they came up with a paper that has recommended in India to use metformin if needed in those patients who are more than 20. So there are certain studies like the MIG, metformin in gestational diabetes. This has already been done, and the SMIG diabetes trial has showed that there is no fetal hypoglycemia despite crossing the placenta, and slight increased risk of prematurity is definitely there. and no benefit in preventing spontaneous abortion in PCOD. This MIG tofu trial, that is those patients with the follow-up with the offspring follow-up, they have also shown that, as Dr. Smita said, that at 7 to 9 years of age, there was some increase in abdominal body fat percentage. Now, again, there are certain ongoing trials, like I'm going into their safety profile, just 2 slides I'll show, that MIT-wise trial, that is metformin in women with type 2 diabetes in pregnancy, still doctors, physicians, gynecologists are giving involved, and till date, it is an ongoing trial. We can also get involved into it. Till date, there has been no recommendations, negative recommendation against usage of metformin after certain period, if needed. So this trial is still ongoing, and probably the pragmatic use of metformin in mild gestational diabetes has come up. And definitely those patients with polycystic ovary who are being treated on metformin ultimately gets pregnant, they ultimately need to be continued. And those patients whom insulin alone can't control the insulin resistance, at 20 weeks of pregnancy, we can add metformin safely as per the FOXI guidelines or FOXI recommendations in March 2021. Thank you. I rest my case here.
Thank you, Shankhoda, for your excellent argument. Now, let me invite Dr. Smita to rebuttal.
Honorable learned members of the House, you have heard much about gestational diabetes mellitus. Kindly consider the following clinical situations. First, a 4th gravida with 3 previous miscarriages comes to you at 10 weeks of gestation with gestational diabetes mellitus. Remember, this is the period of organogenesis. Second, a 2nd gravida with previous 3rd trimester sudden intrauterine death comes to you at 34 weeks of gestation with gestational diabetes mellitus. And finally, a primary gravida with an IVF pregnancy after 9 years of infertility presents to you at 24 weeks of gestation with grossly deranged sugars. I challenge my opposition to convince this House that anything but insulin is the only safe option for these patients. And with that, I rest my case. Thank you.
I would not have been here for the rebuttal because the last question was a challenge and it was a question. So I have to answer because it's against the debate. But I have to answer. She has said 3 cases. I can also give 3 cases, but that's not important. If we can carefully choose our patients of appropriate gestational age, of appropriate insulin resistant, if uncontrolled on insulin, as I always said in the beginning, I agreed that insulin is the first modality of treatment, it's the safest option. It's not the only safe modality which have been covered in our armamentarium. So it can be discussed in case by case basis. If we can think that appropriately we can use in particular cases, metformin is there and now recommended by your organization, which I like to highlight. That is very important.
Thank you, Shankhoda. Metformin, indeed, it is an option but the discussion was on GDM. It was not included type 2 diabetes mellitus. But most often we get a patient with lady with polycystic ovarian disease or infertility. They are already on metformin. Previously, it was thought it was a matter of debate that whether or not metformin to be continued. Initially, we used to continue metformin up to 12 weeks in order to prevent miscarriage. It is well documented, it is well established that it prevents miscarriage. But nowadays, the notion is if patient is on metformin, we should continue with metformin. We can continue till delivery and even after that. Only the thing is that the morning dose must be omitted before conducting a delivery or cesarean section. And another thing I must say that metformin and insulin, in our experience, both of them are very good drug. It is beyond debate that insulin is the gold standard. But most often, in addition to gold, we often use silver, platinum, diamond, etc., etc. So often we require to use metformin and insulin both. The debate was whether it is the only option, but it is the best option beyond doubt. I think Dr. Shankho Sen will also agree to it. And finally, I must say that metformin and insulin, they are both the brothers of the same boat, but I don't know their gender, whether they are brothers or sisters. But I can quote so many cases where initially we had to use or used insulin, but we were unable to control blood sugar during pregnancy. And we had to use insulin sensitizer, that is metformin. I must not say a lot because our third umpire is there with Mike, Dr. Arundhati Dasgupta, and whenever we are in dilemma, we send the patient to her for her opinion. So after Vishwajit sir's opinion, please, you say the concluding remarks.
So after long debates of insulin and metformin, as Smita has told, there are a few delivery patients where only metformin will not suffice. This type of patients, we use combination of insulin and metformin. So we know the insulin is the best, but in some of the cases, the combination of insulin and metformin is required. For today's era, even the gynecologist, we know diabetic, but I think in front of all medicine people and the endocrinologist, it's better to refer the patient to them to have a better treatment of the diabetic, because ultimately multi-specialty approach is important. Ultimately, our newborn baby should be very much okay. As you know, today's, because of ill treat or maltreatment of the diabetic, gestational diabetes, we lose many of the babies. So thank you very much. I think we should not quarrel between insulin and metformin. Both are very important for our mother and the unborn child. Thank you very much.
Thank you, sir. Because Dr. Sandeep has asked for a concluding remark. I think the reason why I chose this topic is that when we see patients of gestational diabetes, we see that some gynecologists are very, very determined to put the patient only on insulin. They will not agree for anything else. On the contrary, we just see the opposite thing also. The sugar levels are very high, but they are only interested in putting the patient on metformin. The consensus statement is every patient is a different individual. Now, when you're treating gestational diabetes, your fasting target is 70 to 90 within 20 milligram, and your PP target is 100 to 120. It's very easy to write that down. It's very difficult to maintain it in all those months of pregnancy. It's very difficult. So when you talk about insulin, that lady who has so many other problems, a lot of them do, injecting insulin 4 times at times becomes a big hassle. Who is going to give the insulin? Where is the insulin going to be stored? How is she going to eat at those regular intervals? Those are concerns. Just the opposite thing also, as she said, some have a bad obstetric history. They're not ready to go ahead with metformin. So we decide on which molecule, insulin or metformin, based on that individual. If I have an obese lady coming at 26 weeks of gestation with slight rise in blood sugar levels, which are manageable by metformin, I will start the patient on metformin. But if I say the levels are very high, I probably will not. But one thing remains, that guidelines do not mention anything except insulin. So we have to be on the safe side. Whenever we are treating gestational diabetes patients with anything apart from insulin, that has to be written down. That has to be written down on the prescription, that the patient and the attendants have been informed that metformin is not a part of the guidelines of treating gestational diabetes. That is important, because otherwise, tomorrow you might be caught in a legal hassle. Because somebody might tell you, I have had patients, attendants coming and telling me, why did you not inform me? I'm not ready to go ahead with anything outside the guidelines. So I make it a point to write this down for every patient in whom I prescribe metformin. But having said that, that was an excellent debate, I think, from all, and we can have a show of hands, sir, if you agree, before winding up. Indeed, indeed. So round of applause for both of them then.
And as a chairperson, I am absolutely unbiased because I have more empathy for the diabetic ladies because I am a diabetic. And I take both metformin and insulin, so I am not a biased person.
Sir, I think this is not my cup of tea, but I have taken this privilege to talk about this. I'm not talking about the technicality that has been talked in length and breadth, but I'm just telling you and the audience that I really like this debate. Smita was really bold and fierce, and Sanko, who is my batchmate, for the rest of the audience to know. What I liked about you in this debate is your maturity. You conceded first that insulin is the best, and then you try to make a space and point for you. Thank you very much. Thanks very much.
Another points I want to highlight. So in case of as a very early diabetic, gestational diabetic patient coming with 150 like PP blood sugar like that, in that type of patients, this conservative management and metformin is the drug of choice because they are, I think the physician and the endocrinologist, they don't give insulin. It's very difficult to control. So in that case, insulin is not very much okay. So that is the one practical point we have seen. Thank you very much.
Just a minute, please, sir. If you permit me, only one comment. Say every debate ends in debate must end with either winner and a defeat, both. But in these patients, both are winners. That has been already decided by the panel of judges. So I do agree with the judges. So I have nothing to say. But Dr. Shankar has said something that pregnancy diabetes is not a disease of insulin deficiency disease. I do agree with that. But treated with insulin. So this lies something like a controversial statement. This has been by a lot of other anti-insulin hormones being produced by placenta, as you have mentioned. But on the contrary, we are not treating with drugs to reduce that resistance, but with insulin. But truly saying, even type 2 diabetes also is a disease of not pure insulin deficiency, but we do treat with insulin in stages or lay down indications where A1C is very high to start with. So insulin is not always only replacing insulin deficiency. It also corrects the other factors causing the hyperglycemia or type 2 diabetes, including neoglucogenesis and so many other factors of the anti-insulin hormone production and other things. So insulin do corrects for that. Number 2, about glyburide, glibenclamide. Every textbook says that glyburide has been tried in pregnancy. But can you mention one physician here who has an experience of using glyburide in pregnancy diabetes? I think the answer is no. Is there anyone who can raise hands that they have used glibenclamide and glyburide already? One endocrinologist has raised in one, so he's the most courageous person in the audience. I have no courage of using that, in spite of being written in some textbooks. The reason is only simple, say, as Dr. Smita said, even if there are laid down indications or there are controversies and all, everyone wants to play a safe game. So always everything is, and Dr. Arundhati, as they have said that we need to mention in the prescription that we have counseled the patient regarding that this is beyond our guidelines and there is a question of legal safety. So how many of us at this juncture wants to take a risk in our profession to write in the prescription and write in the drug as well as counsel the patients that this is beyond our recommendations? So ultimately, yeah. Now, if I can explain, I can write. But if you understand the literacy level of the patients, it becomes practically little difficult. That is, it becomes practically little difficult to counsel. So ultimately, what will happen is that if we want to play a safe game, insulin is the only answer, and probably insulin is the only answer. And only
Definitely,
few
Dr.
patients,
Nath,
few
actually, what is our target? To get a healthy baby from a healthy mother. And we must follow the legal norms because outside the West Bengal Medical Council, Dr. Kunal Shah is waiting. So
He's
that
all
is
the
why
time. He's
we
already all
must
the
be
time.
very much careful. So with this,
ইনসুলিনের তো অনেক ডিসঅ্যাডভান্টেজ আছে, মনিটরিং থেকে শুরু করে হাইপোগ্লাইসেমিয়া,
but at least our patients are in safe hand. Gynecologically, they can be jolly well tackled by Dr. Smita. And if Dr. Smita consults Dr. Shankar Sen, probably the proper advice and guidance she can get. Thank you all for your patient hearing.
Unofficial point, the chairpersons have concluded it. একটা important point, প্রচুর patient আমরা পাই যারা initially they refuse to take insulin despite counseling. That also definitely I write down that despite counseling, that patient has refused to. So we are starting with oral antidiabetic medications, which I feel to be safe and ultimately will need insulin if the situation demands. This can you write because we get patients who refuse insulin even in our diabetic practice, not only for diabetes. Like
Dada,
obese young.
I don't mean to debate again, but then once, you tell a patient that there is a chance of, abnormalities or her baby having diabetes, blah, blah, whatever I have said, I don't think most mothers would choose metformin. They would all choose insulin. Yes, it's the only time where the mother will put her child before herself, whatever it takes. So whenever we prescribe insulin, we are always in the safer lands. And I think we need not be, in fact, too heroic.
Dr. Smita, there are so many other sessions and we should not allow the pregnancy to go beyond 42 weeks. So pregnancy must be terminated.
Thank you, doctors. Thank you for this wonderful debate. I would like to request Dr. Vishwajit De sir to felicitate Dr. Shankar Subroshen sir. And I would also request Dr. Sandeep Sengupta sir to felicitate Dr. Smita Das Ghosh ma'am. Sir, I'm repeating once again. I would like to request Dr. Vishwajit De sir to felicitate Dr. Shankar Subroshen sir. And I would like to request Dr. Sandeep Sengupta sir to felicitate Dr. Smita Das Ghosh ma'am. And once again, I would like to request Dr. Shankar Subroshen sir to felicitate Dr. Sandeep Sengupta sir. And I would like to request Dr. Smita Das Ghosh ma'am to felicitate Dr. Vishwajit De sir. Thank you so much, doctors. And moving forward to our next scientific session, that is workshop on diabetic food. I would request Dr. Dasgupta to please come up on the stage and brief the topic, please.
Yavraj.
And moving forward to our next scientific session, that is workshop on diabetic food. I would request Dr. Andhuri Rajgupta ma'am to please come up on the stage to brief the topic.
So we are in the middle of a lot of important academic discussions. But regarding diabetic foot, this is one condition. When you see the patient as an endocrinologist, I'm confident enough to deal with all complications of diabetes. I can deal with them at least, even if not to the highest level. Nephropathy, neuropathy, retinopathy, I know what to say, what to do. But the moment that patient comes in with that smelly, gangrenous, diabetic foot, then you are stuck. Because you don't know how much can I really do to help this patient. I'll control the blood sugar, that's all right. but I'm going to talk about offloading. I don't even know if he's going to understand who's going to follow this up. Who am I going to refer this patient to? How long can he go without work? I mean, these are very, very practical issues. And truly speaking, I'll admit that I probably do not do justice to all my patients with diabetic foot. And I think a lot of other people who are into diabetes practice would also agree that we do not really have these setups most of the time to do enough justice for the diabetic foot patients, sir. So today we have amongst us Dr. Ghanshyam Goyal, and he is one diabetologist who does justice to diabetic foot, we must admit. So today we are here to learn from him as endocrinologists, as physicians, as surgeons, that what can we do to improve the lives of our patient with diabetic foot? Not the question answers that we write. We can all write 10 pages answers on diabetic foot, but practically, how much can we do? What can we do to make the lives of these people better? So that is why this topic was chosen, and I'll welcome the chairpersons for the session, Dr. Kaushik Bhattacharya and Dr. Shomitra Shah, sir, to please come up and place your views and please introduce the speaker. Thank you so much.
Good evening. Good evening.
With the permission of the House and Dr. Arundhati, I am here. Just one thing before the chairpersons introduce, sir, please, Ashok. I feel when we think of diabetes foot in this part of the world, I, as a physician, as a diabetes practitioner, and I remember one name, Dr. Ghanshyam Goyal. Like, he's a legend in this field, and today we are proud to have him here.
Ladies and gentlemen, I want everybody to come. The younger generation, please come in front. All postgraduates, come in front. Because we are going to discuss some topic. After that, you cannot eat. Now it's smelly, as Dr. Arundhati was saying. Smelly, gangrenous, rotten. So please come in front. I don't want you to be behind. There are vacant seats in front. Come down, come in front. Yeah, come, please come. Please join us. No, okay. And I think I joined Dr. Shomitra Shah in welcoming Dr. Ghanshyam Das. And when Dr. Arundhati called me up and said, we are going to have a session on diabetic foot, sir, believe me, I have to admit that I was very happy. I said, I'll talk. She said, no. There's one very personal person who is coming all the way from Calcutta and he will talk. So probably for the first time, the two surgeons are on the other side of the desk. And here we have an esteemed diabetologist from Calcutta. And believe me, I know him personally because he has very recently written a meticulous and very good book published by Springer, sir? JP Brothers. Okay. I was reading that book. It has been published by JP Brothers, and it has been widely accepted as a Bible for diabetic foot. I welcome you, sir. Please join us.
Good evening.
Thank you very much, Chairperson, sir, and colleagues and friends. First, I congratulate Arundhati and Joydeep for starting a diabetes update. And as she mentioned, it is a teamwork. So I think my job has been done already because diabetic foot is a teamwork. That is one. And second thing, regarding the diabetic neuropathy, which Joydeep have shown the cases, all three cases, very good cases, in which we have shown the diagnosis of exclusion. That is very important. So that should be kept in mind. So that is the point. And about the diabetic foot, it is one of the most neglected part, as Arundhati told. And believe me, sometimes I feel bad about these patients. I started actually diabetic foot in 1998, around 25 years back. And we started the full-fledged clinic in 2000, year 2000. And we are doing a lot of work on diabetic foot. And still, sometimes we find in dilemma how to deal with this problem. So friends, with this background, I'll just start with, today I'm going to discuss regarding the diabetic foot management practical tips for the physicians. Change hocche na? Slide. Na move hocche na. Probably. So everybody have listened this proverb, prevention is better than cure. And it has been around 5 centuries back. Erasmus is a Dutch philosopher who came with this. And this hold true for the diabetic foot, because prevention is the key in diabetic foot, and physicians are the first point of contact for any patients. And physicians play a very important role in identification and prevention of diabetic foot. Cost of diabetic foot ulcer is greater than out of 5 most common cancers. Remember it. Even CA breast, CA prostate, CA cervix, CA lung, the cost of the treatment is so high, so you should remember it. Every 20 seconds, someone is amputated. Lifetime risk of diabetic foot ulcer, we used to say around 15%, but now it is staggering 34%. Means 1% or every third person in their lifetime is going to have a diabetic foot ulcer. And then 20% of the diabetic foot infections results in a amputation. Remember it, out of these ulcers, around 50% of them are infected. And after major amputation, 50% of the people will have other limb amputated within the 2 years. This is the grave situation. Next. Diabetic foot ulcers, the median time to healing a DFU without surgery is approximately 12 weeks. And they are associated with the high risk of limb loss through amputation. Remember it. Even if you follow all the 3 basic principles, adequate debridement and infection control, adequate vascularity, and adequate offloading. If you follow all these 3 basic principles, even after that, there is a high risk of limb loss through amputation, and 5-year survival following presentation with a new DFU is in the order of only 50%. The mortality and cost of 5 most common cancers, it is much more in diabetic foot than the 5 most common cancers. Next. Association between mortality and DFU was stronger than that of any macrovascular complication or disease. And it has been estimated that global cost of diabetes in 2015 was 1.3 trillion. And it has been reported that 1/3 of diabetes expenditure is on lower limb related problems. Remember it. I remember in 2015, I was there in US for 2 weeks for one of the largest clinic on diabetic foot in the Ohio State University. I visited 20 clinics, and you see the situation is much worse than ours. Only thing is they have got more advanced gadgets, but situation is much worse than what we are doing. Next. So lifetime risk is around 34%. It is not the 15 or 25%. Next. It's not moving, so it could have been better. So recently in 2017, a very important paper has been published by Armstrong, Bolton, and Bush. They are the big names in diabetic foot. And what they have mentioned, the lifetime risk is 34%. And second thing, the 1-year ulcer recurrence is around 40%, and 3 years recurrence is 60%, and 5-year recurrence is 75%. So means whenever a patient comes to us and if we'll say your ulcer is healed, we should not use the term your ulcer is healed. We should say your ulcer is in remission. So they will take care of their feet. So because lifelong the examination or lifelong follow-up is very important in these patients, and they should be followed up for lifelong once they are having foot ulcer. Next. Who is at risk of foot ulceration? We all know it's a neuropathy. Patients who are in diabetic peripheral neuropathy, peripheral vascular disease, past history of foot ulceration, microvascular complications, then poor glycemic control, smoking, foot deformity, and amputation. These are the risk factors. Primary risk factors is neuropathy, peripheral vascular disease, and then these are the secondary risk factors. Next. There are 5 key elements that underpin the prevention of foot problems. So this is for the physician. Identify at-risk feet. How will identify? By doing comprehensive examination every year, which I am just going to show you and discuss. Regularly inspecting and examining the at-risk feet, educating the patient, family, and healthcare professionals, ensuring routine wearing of appropriate footwear, treating risk factors for ulceration. Next. So this is the comprehensive foot examination. If patient is not having no LOPS, means loss of protective sensation, no PAD, peripheral arterial disease, no deformity, then even a generalist or a physician can do a comprehensive foot examination once in a year. That is important. Then if patient is in LOPS, loss of predictive sensation plus minor deformity, then you can have a every 6 month foot examination could be done. If a patient who is in peripheral arterial disease plus LOPS, then in that situation every 2 to 3 months. But very high risk category or risk category 3, ulcer or amputation history, every 1 or 2 months, or whenever patient visits you. In these patients on Charcot's also, you have to go for it. Next. So how to prevent, how the prevention can come? We start our examination from head to toe. You start your examination from foot to head, means toe to feet, means apada mastak. And whenever a patient, diabetic patient comes in your clinic, please ask him to remove the shoes and socks and examine the feet, which will prevent the amputations. Next. So typical diabetic foot presentations at the clinics. Next. We all see this sort of presentations. It's not working. This is a bilateral great toe ulcers. You see, is it not working? Can you change the battery? So I think so. So bilateral great toe ulcers. It's very difficult to offload the bilateral ulcers, and it's the bilateral first empty metatarsal head ulcers. Next. This is a infected hot back compression following fall. Patient was in severe pain, but as there was neuropathy, so he was not feeling, and there is a hot back compression, and this lead to this sort of disaster. And this is a limb to life-threatening infection. And as we were discussing, odor or fall smelling, it's amending, and it's really sometimes you are feeling to vomit. That sort of the odor is coming from these patients. To control the odor is also one of the important aspects in management of diabetic foot ulcers. Next. So with these, by seeing these clinical scenarios, what is the common scenario? First, second, third, unsuccessful home therapy. একটু ফুসকারি হয়েছে, আমি ডাক্তারবাবু কেটে নিয়েছি, আমার মনে হচ্ছে ঠিক হয়ে যাবে. People are like that because they are not in pain due to loss of protective sensation. And then visit to local physician, application of unproven therapies, and then visit to primary care center, district hospital, regional hospital, probably not aware of the management of diabetic foot, leading to sepsis because of delays. And then referral to specialist care. Most cases ulcer progress to gangrene or systemic infection, resulting in the poor outcome. That is the usual story we all come across in our day-to-day clinical practice. Next. No. So learning from the above cases, what we have learned, most of the cases should have been prevented. To prevent DFU, we have to also understand and address the challenges and barriers to the foot care. Next. Kunda, next. So challenges different from different countries. This is a very common scenario in the hot, humid climate during the month of May or June. You can find walking to the barefoot to the temple. Physician role, educate their patients not to walk barefoot. Remember it, if you are in LOPS, loss of protective sensation, or you have got neuropathy, do not walk barefoot. If you are not having neuropathy, you can walk. That, remember it. This is very important. Sleeping in the open, which is very common in our rural areas, and rat bite by sleeping on the floor is most common thing. And then ant bite. So patients or physician's role is educate their diabetic patient not to sleep in the open, and if possible, wear those shocks. That is very important during the sleeping time. And this is about the footwear. Infection in the foot are often caused by wounds resulting from either wearing non-protective footwear or poorly fitting footwear, or wearing no footwear at all. This was a intelligent guy. What he have done, that he have put this silicone in soles, and he was in ulcer at the seam areas. You see, these are the seams. So these are the areas, and where. So we should always, whenever a patient comes to you, please inspect the footwear being used by the diabetic patients. So that is the message from this. So what are the challenges? Challenges are lack of finance, non-availability of nearby clinics, lack of knowledge that consultation required, and delay in seeking medical help is very critical. Time is tissue, as we do in cardiology or MI. So use of antibiotics without proper prescription, inadequate doses result in infection caused by more antibiotic resistant organisms. So Physician's role is educating patients not to use antibiotics without prescription. Most neuropathic uninfected ulcers do not require antibiotic therapies. Remember it. This is the application of unproven therapies. Patient was in severe pain. So it was actually an intermittent claudication pain. And he consulted physician who advised to put a crepe bandage. He put it tightly and he precipitated the gangrene. You can see the gangrene, all these, the great toe, second and fifth toe, and landed with this problem. About the physical examination, how you will diagnose the neuropathy? Simplest thing, 10-gram Muram filament test, and you test at only 3 places now. It is not the 5. Great toe, first empty head, and 5th empty head. Out of these 3, if your patient is unable to feel at 2 places, then patient is having loss of protective sensation, or patient is having sensory neuropathy or diabetic polyneuropathy is there. So it is, remember it. And then about the diminished vibration perception threshold, VPT, if it is less than 25, then patient is having diabetic neuropathy. And about the tuning fork, 128 hertz tuning fork or graduated tuning fork can be used. And if you find there is a diminution of the vibration perception, it means patient is having neuropathy. Then absent ankle reflexes. And these are the signs by which you can feel that patient is having neuropathy. Because you see, neuropathic ulcer will always be in the plantar surface and pressure or weight bearing areas. And there is a lot of callus around the ulcers. So if there is a callus around the ulcers, it means there is good supplies, blood supply is adequate. By just having a look, you can say it's a neuropathic or it's a ischemic. So it's a neuropathic ulcer. Great toe again, and remember it about the great toe. It's the most important in the waking cycle. And great toe, we call it not the first toe, we call it as a great toe. And you see, 1/3 of the ulcers which occur in diabetic foot is on the great toe. So there are 2-3 examinations. One is, I know all are busy clinical practitioners and not having much of time. So in the beginning, I just mentioned it's a teamwork. You alone cannot treat diabetic foot. I've got a team of my nurses, educators, then my podiatrist, surgeon, everybody. So team is there. So without that, so in foot examination, 60-second examination, 3 minutes examination. There are 2 types of examination. Any previous diabetes-related foot problems, or both foot pulses palpable? Is protective sensation intact? Is there evidence of significant foot deformity? First 15 seconds, you have to ask this question. Then next 15 seconds, do ever they tingle, and final 30 seconds, do they ever burn? Do they ever feel? Check for something. So this is a very fast physical examination, and you find in 60-second examination, yes, patient is having high risk diabetic foot. Then you go for a comprehensive foot examination. So this is 60-second screening protocol which has been done in Guyana, Georgetown, which is a poor country in South America, where they follow this protocol. And what they have come out with this, they found major amputation reduction by 48% at the end of the 2 years, so which was very important. Remember it. Then 3-minute examination. One is what to ask, what to look, and what to teach. These are the 3. So first minute, what to ask? Patient is a previous history of leg ulcer, prior angioplasty or stent or leg bypass. I'm not talking the coronary artery bypass or the leg bypass, or smoking, nicotine use, patient of burning, change of the skin color, loss of lower extremity sensation, all these. So what to ask in 1 minute. Then second comes what to look for. So there are 4 things. One is dermatological examination. Then you can have a neurological examination, musculoskeletal examination, and the vascular examination. All these 4. So in that you can go for this, that you all these, if you find if they're ingrowing toenail or the patient have interdigital maceration, always remember it's a very common patient. If you have to check each and every patient's interdigital spaces, because there is a interdigital maceration or interdigital mycosis, very common, and which may lead to the amputation and fungal infection grows inside. So always remember it. This is very important. What to teach? Then education regarding the shoes, daily foot care, and smoking cessation, all this. So this is a 3-minute foot examination. This is a comprehensive foot examination. It will definitely going to give you results. And what is the outcome measures? That you are going to prevent the amputations. And even forget about the minor, even the major amputation can be prevented if you will have this 3-minute examination. So you have to inspect for the nail dystrophies, arrhythmia, prominent veins, callus. Don't be callous for the callus. I tell you, this is very important because callus or thickening of the skin occurs at the high pressure areas, and most common is the great toe, first, third, fifth anterior and the heel areas. These are the areas where it is there. So if the callus is there, please remove it. Otherwise, it is going to cause high pressure area, skin will back down and patient will land with the ulcer. So don't be callous for the callus. And swelling of the feet, fissures, dermopathy, foot deformities like clatoid, hematoid, bunion, gross deformities of midfoot, that is Charcot's foot. This is one of the very dreaded complication of diabetic foot. So you have to look for callus, just like this. This is the callus. Because there is a loss of protective sensation in these patients, you just take a number 10 or 15 blade and blade handle, and just you can remove in your clinic. You didn't need any this anesthesia or any OT setup or and all that. And if you remove this callus, there's a reduction of plantar pressures by more than 30%. So chances of formation of ulcer goes down. So about the deformities occurring in a foot with other risk factor increases ulcer is clawing of the toes and Charcot deformity and hallux valgus. This about the Charcot's foot here, just I want to mention one thing. You should have a high index of suspicion. That's the most important. Patient having difference of 2 or more than 2 degrees centigrade with the contralateral limb, and you have excluded other causes. Gouty arthritis, cellulitis, osteomyelitis, and DVT, deep vein thrombosis. After that, you can have a suspicion of Charcot's foot. And dense neuropathy is mandatory for these. These are the different cases of Charcot's foot. We have got around 123 cases of Charcot's we have treated in last 25 years. So that is their big series. So which is there. And always remember, whenever a patient comes to you, please put your fingers on the pulse. That is the one is dorsalis pedis, other is tibialis posterior. And if it is palpable, it means vascularity is adequate. And if it is absent or feeble, you have to think of ischemia. If it is bounding, it means it's a neuropathic. Just by palpating the pulse, you can differentiate it's a neuropathic, it's a ischemic, or it's normal. If it is bounding, it means neuropathic. If it is feeble or absent, it's ischemic. And if it's normal, palpable, then it's normal. Or about the neuropathic foot, it will be on the plantar surface, high pressure areas. There will be a lot of callus because you need a lot of blood supply to have callus, and then wet and gangrene will be always wet and infectant, and leaks protective sensation. You cut it, they will not have any sensation because there is loss of protective sensation already there. So you evaluate the neuropathy by these, and most important test is the monofilament test. And how you'll do? Just test at this 10-gram monofilament, 1, 2, 3 places. If out of these 3, a patient is unable to feel at 2 places, means he's in dense neuropathy or loss of protective sensation is there. This is the International Working Group Guidelines 2019. This recommendation is this. So about the PAD, peripheral arterial disease is the major risk factor for foot lesions. Neuropathy and PAD, that is a neuroischemic foot, often coexist, may lead to neuroischemic ulceration. So always remember, and even till today, I'm yet to see a patient who is not using tobacco in any form, either a smoker or chewer, tobacco chewer is there. So tobacco is in very strong correlation with the peripheral arterial disease. It is generally not cold, it's generally, it's okay. It's not pink, it's black. It's pulseless, it's marginated ulcers, gangrene, and it's not May. It's always very painful because there is no blood supply. So these patients are unable to sleep in the night. They just beat their feet with the bed. That I'm so painful. These are sometimes so painful. And how to do the test? One is the palpation of pulses. Then you do a ABI, ankle brachial index. I think I not need to discuss with everyone. Everybody knows less than 0.9 is abnormal ABI in between 0.9 to 1.3 is normal, more than 1.4 is, or I can say raised or systemic or medial sclerosis or Monk's sclerosis, means calcification of arteries there. And remember it, whenever a patient with diabetic foot comes, please have an X-ray, because this is very important. I'm just going to show in different cases how you can guess, and you can do a ABI. If you find yes, it is suggestive, then you can go for angio and other invasive procedures. If otherwise, it will be good enough. So what are the basic tenets of diabetic foot management? Adequate debridement and infection control, then adequate vascularity established. If a patient is not having adequate flow, you have to do a intervention, either a peripheral angioplasty or do a peripheral bypass, or you can do a hybrid procedure. Once you can at one place you can do a plasty, at one place you can do a pedal bypass, like that, and you have to do adequate offloading. And remember it, in India we have got around 85% of the patients are having neuropathic ulcers, 15% are neuroischemic or ischemic ulcers. But in the contrast, in the Caucasians, US or European countries, it's 1/3 neuropathic, 1/3 ischemic, and 1/3 neuroischemic. So because to treat neuropathic ulcer is much easier than to treat a ischemic ulcer. So remember it. So about the antibiotic regime, so don't put it non-limb threatening, or life threatening. You can put mild, moderate, or severe infection. So how you always take a deep tissue culture, and then what you will do is start empirical antibiotic therapy. So it should cover both gram positive and gram negative, because the most common organisms which are responsible for the diabetic foot infection is staph and streptococcus. So it should cover a gram positive coverage, and the most common antibiotic which we are using amoxiclav, and then you can use a quinolone, that is either ciprofloxacillin or levofloxacillin, because gram negative coverage is also there. So that one, and remember it, the duration of therapy should be at least 2 weeks for the mild infection. For moderate infection, 2 to 3 weeks, and for the severe infection, it should be 3 to 4 weeks. It should not like be just we give for our URI or other thing 5 days or 7 days. It should be longer duration of antibiotic therapy. And patient is in osteomyelitis, then you have to use the therapy for minimum 6 weeks, and it ranges from 6 weeks to 3 months. So that is very important. Always remember it. About the management of comorbidities, about the cardiac part, as Arundhati will agree with me, if you are having a peripheral arterial disease, you are having very high chance to having a subclinical coronary artery disease. That is one. And in these patients, the risk of death at 10 years is 4 times than in the patients who are not having the peripheral arterial disease. But if you are in coronary artery disease, it is not necessary you will have a peripheral arterial disease. But if you are in peripheral arterial disease, you might have coronary artery disease. So you have to take care of comorbid conditions. Then retinopathy, nephropathy, peripheral vascular disease, depression, and other dysfunction, erectile dysfunction. All these has to be taken care in this situation. So then comes the offloading. The most common part in our country, we are just lacking is the offloading. Because most of the patients who are coming ulcer since 1 year or 6 months, and what was lacking, offloading has not been done. Because the neuropathic ulcer, as I have already discussed, around 85% are neuropathic, are only on the plantar surface, not on the dorsum or on the margins, because on the margins it's the ischemic. So what happened, the offloading has not been done. So removable devices, the gold standard is total contact cast. Then TCC with window we do for the long standing ulcers where the lot of secretions are coming, to drain that secretions, and instant total contact cast. And then removable devices, lot of devices are there, footwears and all that. And one of the technique which is indigenous offloading technique, I'm just going to show you. That is a very perfect thing, and it is very useful in clinical practice. You can practice at the primary care. Forget about the secondary or tertiary level. This is a very simple way. We name it after our center, SK offloading. So indigenous techniques of offloading. Change hochche na baba. Battery auto there is offloading the diabetic foot. This is the front offloading shoes, outer. You can see. Then is the total contact cast, is the posterior slab. This is the SK offloading, what I was discussing. These are the, you can take a foam, piece of foam, roll it, and just wrap in a piece of gauze and then stick by the micropore. You see there was an ulcer, and here how we have given this, so there is offloaded. When a patient will stand, so there will be no pressure on the ulcer. So this is the way you can do. And we have done a total contact cast with a window inside, so that you can see. So that is the way you can go for offloading of the diabetic foot. Education of patient, family and healthcare providers about the foot care. Education in a structured, organized, repeated manner is widely considered to play an important role in prevention of diabetic foot ulcer. Healthcare professional providing these instructions should receive period of education to improve their skills in care for patient high risk for foot ulceration. Foot care. I'm just skipping all these slides. Can you change? Yeah, it's a very important thing. Whenever a diabetic patient who is in neuropathy, loss of particular sensation, they should buy the footwears in the afternoon, because due to neuropathy, there is some swelling in the evening. So in the morning it is okay, but in the evening there is a pressure. So they might be due to that pressure ulcer. So that is a one I want to just give a message. Never wear new shoes all day. That is very important. Foot care instruction, most important, do not walk barefoot. That's all. If you take this message, even indoors, forget about the outdoor. If you have got neuropathy, please do not walk barefoot, even at your home or indoors. Therapeutic footwear, I'm just going to show you 5-7 things which are very important. Wear appropriate footwear that fits and protects their feet. Wear socks to reduce shear and friction. Educate on the importance of wearing appropriate footwear. I just want to no, take it. Thank you. Then obtain footwear from the trained professional. And fifth is the most important thing. Wear appropriate footwear at all times, both indoors and outdoors. If you are in loss of protective sensation, always remember it. Check footwear before wearing and check feet after wearing. কারণ একসঙ্গে নতুন জুতো নিয়েছো, ওই সময় দেখবে প্রেসার পড়েছে ও লাল হয়ে গেছে, patient is not able to feel because of neuropathy, and that may be disaster. So always remember it. And then they review prescribed footwear every 3 months. In our country, due to the cost constraints, we say every 6 months. 3 months is not possible for a general patient, so that is very important. Just straightforward, I'm coming to this. So with this background, I think now you are able to understand how to manage diabetic foot. Always remember 3 basic principles: adequate debridement and infection control, if it's there; adequate vascularity; and third is adequate offloading. If it is there, then most of the cases you are going to have remission of ulcer, or you can healing of the ulcer will be there. But even after that, if the ulcer is not healing, either you revise diagnosis, means if you are thinking it's a neuropathic ulcer, it means it's not neuropathic ulcer, it's a neuroischemic, probably that's why it's not healing, not an adequate blood supply. Or you have to use the advanced wound healing modality, just like negative pressure wound therapy, or you can have the platelet derived growth factors and other things. Even the not the hyperbaric oxygen therapy, I'll say the topical oxygen wound therapy, TOT. That is all these things there. So this patient, এটা হবে কিছু, কারণ this is very important, so show them. Pointer নেই কি? হ্যাঁ উপরটা, হ্যাঁ. This patient come with this ulcer and this on here. So it was the midfoot in the second and third empty head areas, and here it is on the great toe. And history of walking barefoot of the temple every morning. She developed blisters, and now ulcer was non-healing since last 5 months. ABI was normal. So it means vascularity is adequate. Both pulses were palpable. Neuropathic assessment, vibration perception, and the monofilament was impaired. As I have discussed, X-ray is mandatory in each and every patient. So you have to do X-ray. X-ray was done, it was normal, means it was not showing any evidence of osteomyelitis. So how you manage these patients? One is, first you go for the debridement, because these are neuropathy in your clinic, just remove it. So just we have removed it, And here we have done the debridement. Only thing why these ulcers were not healing, because offloading was not done properly. So you see offloading has been done, and what was the result? After 15 weeks, still after doing all these, it takes 15 weeks. As I have discussed in the beginning, the normal time to heal diabetic foot ulcer is minimum 12 weeks. So take 15 weeks and you see the results. You see the final results. So these were a neuropathic. Probably, I'll say we have given antibiotic for 2 weeks. It was a neuropathic infected bilateral ulcers, one at the third empty head, other is the great toe, and it was not healing due to the inadequate offloading. So only thing which helped in healing the ulcer was the offloading. This is the first case. So this sort of cases I think you might have seen in the past, or I don't know about this. Very advanced extensive gangrene of the whole of the left foot with involvement of lower 1/3 of the leg. You can see this. And foul smell, blood pressure was low, patient was in septic shock. And on examination, pulses were palpable, and destruction whole of left foot with extension in lower 1/3. Creatinine was AKI high, it's 2.9, hemoglobin low, patient was transfused, resuscitated, albumin was given, blood was given, and patient's family members were counseled about to save the life. Sometimes you have to do the major amputation. Major amputation means either below knee or above knee. So below knee amputation to save the life of the patient. You have to choose between limb or life. So in that situation, we have discussed the family member, and after that, major amputation has been done. And after 6 weeks, below knee patient amputation was provided with a below knee prosthesis. Below knee amputation is a life-changing event. It is the last resort when all options of saving the limb have failed. And sometimes DK are performed in order to save the life of the patient. Advance in surgical procedure, improved and advanced processes have enabled patient to return to almost near normal life post amputation. So in that situation is there, you have a lot of patients who are having this sort of problem and they are coming walking. You cannot realize that he had an amputation also. So sometimes it happened. These are very advanced cases where, and it was a neuropathic. Remember it. It was not a peripheral vascular disease or PAD which happened. In PAD it happened, then you can accept, but in the neuropathic it is very difficult to accept even. So this is the patient, 70 years male. What I discussed, he was in intermittent claudication and he have applied the crepe bandage. He had the gangrene of first, second and fifth toes, and pulses were not palpable. He was in very severe pain and ABI was unrecordable. So we just directly underwent for the angiography of the lower limb arteries and found there's a complete block on the right foot from the superficial femoral artery downwards. And there was on the left also, there was a complete block, but there's a distal runoff, means anterior tibial, posterior tibial and terminal arteries were visualized. So that is there. So, and actually my videos were not running, so I'm sorry. I'm not able to show you the videos. The angioplasty has been done and there was a stent, little on a stent, that is a very long stent, around 15 centimeter long, has been put in the superficial femoral artery and ABI has been improved. And amputation of second, fifth and partial amputation of great toe has been done. Regular dressing, medical management continue. Patient is still pain. So in that patient, we use the ultrasound debridement, but still we are not getting the result. So what happened when we have done a ABI, we find the ABI has gone down again, which was improved after the angioplasty. So it may happen in diabetic foot patients. And what we have again after 3 months repeated a balloon, repeated angiography, and it was found that there was an in-stent stenosis in the stent, which is generally not there because these are large stents, 15 centimeter and 6 millimeters in diameter. The coronaries are 2 to 3 millimeters, we can say, and the femoral is around 5 to 6 millimeter in the diameter. So still there was a balloon dilatation with the drug coated balloon, that the paclitaxel has been done. And after that, again, it has been improved ABI, and patient was given with the posterior slab support, and the patient has been improved. And finally, these patients should be under lifelong surveillance. That is very, very important. Always remember, it took 9 months to heal this ulcer by this patient's ulcer. Ultimately, we were able to save this patient's limb. This is very important. Just 15 days back, we have got this patient from the Bihar, Sahibganj, 59 years, type 2 diabetes, 12 years, blackening of right great toe. You see, so this is important. I want to just show you. There's a gangrene. You look, that is the gangrene. Rodent bite history 3 months back. Gangrene of right great toe. You can able to see it. So we have done an X-ray, and you see this X-ray was done 2 months back. He brought in that X-ray also there was evidence of osteomyelitis, but now you see it has been destroyed totally. You can see even the empty metatarsal heads and even the digits both are involved. But if you'll go for, if you'll see the picture, it doesn't look that patient will have osteomyelitis. So osteomyelitis was there, and I think both the chairpersons are surgeons. So you have to remove from here. Otherwise, there is a chances that bone will stuck, that infected bone, and again this ulcer is not going to heal. So that is the importance of the having an X-ray in these patients. And these were the investigations which were showing X-ray of the right foot osteomyelitis, ABI was normal, and after amputation, this was the picture. And yesterday the closure has been done in this patient. It changed. This is we have applied the vacuum assisted closure, and you see the color. It means adequate vascular the vascularity, and then it's closed. So after wound closure, so it is a neuropathic, infected, or diabetic foot osteomyelitis case, and where the gangrene of the great toe has been occurred. That is one. And this is another case where you see the blackening of the or gangrene of the great toe. Again here, history of great injury at great toe followed by hot water fermentation because patient was in pain. So difference is, in the previous case there was no pain, but in this case there was severe pain. Patient was just tossing with the pain, and that gives a hint that it might be ischemic ulcer. So, and here both the pulses are not palpable. In the previous case, both the pulses were palpable. Both the pulses were palpable, both tibialis posterior and dorsalis pedis. But in patient, both the pulses were not palpable and ABI was unrecordable. So what we have done, we have subject this patient for the peripheral CT angiography or CT angio of the lower limbs. And we find that occlusion of mid SFA, superficial femoral arteries, severely diseased, and mid distal SFA in left side, and focal stenosis proximal ATA, anterior tibial, dorsal pedis, and PTA. Peripheral angioplasty was done. Below knee angioplasty plus superficial femoral artery stenting has been done by the vascular surgeon. And you see here again, you find there was a osteomyelitis. You see, you could have missed. So if it means we have to go for the amputation from here. But in this patient, we doesn't go amputation before doing a angioplasty. So in this patient, first you increase the vascularity by doing a angioplasty. So angioplasty of the peripheral or lower limb arteries, the superficial artery, femoral artery has put a stent, and a balloon angioplasty of the anterior tibial and posterior tibial artery has been done. So after increasing the vascularity only, you should go for the amputation. So you can see the difference in the color of previous patient and this patient. You can find a lot of difference. That was red at the fleshy, just like fleshy, but it's not so much. But even after plastic it happened and the closure has been done. So you see, so huge difference. Both cases showing gangrene of the great toe, but one was on account of neuropathic infected, and other was on account of ischemia. So that is the important thing. So this is the message I want to give, and just I'm going to show you final case. Yeah, Charcot's, as I've already mentioned, more than 2 degrees difference with the contralateral limb. patient having some difficulty, some pain or redness and swelling, especially the midfoot and the loss of arch of the midfoot, and you exclude other causes of Charcot's, that is gouty arthritis and deep vein thrombosis, osteomyelitis, cellulitis, all these. And then you should have a high index of suspicion to have a Charcot's fit. This patient come to us with the nephrology department, and he was waiting for he's a type 1 diabetic, and he was complaining of swelling of right foot for 7 months, treated for cellulitis for past 4 months, and he was waiting for the renal transplant. You can see midfoot has been collapsed. Midfoot has been collapsed in the plane, and there is swelling, and temperature difference between the contralateral limb was around 2.5 to 3 degrees in this patient. So type 1, 22 years, hypertension, retinopathy, CKD stage 5 on maintenance hemodialysis, planning for renal transplant. And we all know the patients who are having CKD or on the renal requiring renal replacement therapy, they are having more chances of having the Charcot's foot. So always remember it. There were difference of 2.5 degrees to the contralateral extremity. Pedal pulse is bounding in right foot, normal in the left foot. So you can see destruction of joints, all the joints you can see. You can see destruction and fractures of the different joints, midfoot Charcot's, typical collapse of the arch of the midfoot. Offloading and immobilization, most important is offloading, and then roll of bisphosphonates, doubtful is still the question mark. Lot of studies shown they reduce the temperature but does not improve the outcomes. Healing rates has not been improved. But about the denosumab, very important. That is the, I think, a good option. Nowadays, we are using denosumab and prevent the new foot fracture. So, high index of clinical suspicion is necessary to diagnose Charcot's. Early diagnosis and treatment can change the outcome. So, dear friends, diabetic foot examination mandatory in all patients. Whenever a patient comes to you of diabetes, please start your examination from foot to head and ask the patient to remove the shoes and socks. Physician should examine a diabetic patient from foot to head. Physician should identify the high-risk feet. Team members of physician should impart foot care education to all diabetic patients at every visit. They're very important. Minor foot pathology and trivial injuries should be managed by physician and team. Complex foot pathology should be referred to heart center. Thank you very much for giving me a patience hearing. And if anybody is having any comments or questions, I am happy to answer. Yeah, thank you. Yeah. Mm-hmm.
Of that case, I would prefer an angioplasty. The patient is not in sepsis, like antibiotic, and if it doesn't heal, then go for amputation.
One thing very important regarding the cutting of the disc, we want to prevent amputation. That's why we have asked the patient to go for an angiography, and it was found that there is a block in the superficial femoral artery, and there was around 70 to 80% block by the anterior tibial and posterior tibial. The total revascularization has been done. After revascularization, it has been done. You can do it after 3 to 4 days. And remember it, whenever you go for any surgery, we stop the antiplatelet agents. Just like we give sometimes triple combination of one is the Geralto or rivaroxabarine and aspirin or clopidogrel sometimes. But in diabetic foot patients, we don't stop the antiplatelets when even you are doing the surgery. Only thing is you have to keep watch of the blood loss, which is very important. Otherwise, we don't go for the stoppage of that. So after 3 days or 4 days of revascularization, you can go for the amputation. Because if you'll not do amputation, what will happen? In this case, as we have done, and then the primary closure has been done, infection may spread upwards. That is one. And due to second question regarding the bounding of the pulses, in cases of diabetic neuropathy, if you understand the mechanism of diabetic neuropathy, there is a AV shunting. There is AV shunting. The blood AV shunting. So AV shunting, there is a bounding of the pulsation. Same thing as we do it for the AV fistula in case of renal replacement therapy. Yeah.
Thank you very much, Dr. Goyal. That was a very comprehensive
sorry.
presentation on diabetic foot, ulcer prevention and management. Now, before I invite more questions from the audience, can I have a
Yes, sir.
few of my own?
It will be my pleasure.
Thank you. First of all, would you consider doing a probing of, say, a grade 3 or a grade 4 Wagner's classification wound in assessing whether there is clinically osteomyelitis or not?
Each and every patient should be probed. It's a grade 1, grade 2, grade 3, 4, 5, because due to the, I've got given a lot of time, 1 hour is more than enough. But still I skip this because grade 1 means superficial ulcer, grade 2, deep ulcer, grade 3 means involvement of
1 and 2, there
osteomyelitis.
is no role for probing.
So if you do a probe to bone test, it confirms that patient is osteomyelitis. And probing to bone test, PTB, is a very highly sensitive test. It gives very high specificity and sensitivity. So each and every patient of diabetic foot should have a probe to bone test. It has to be done.
The other thing is, which you didn't mention in any of your slides, is would you consider a screening colored Doppler study for these patients?
In what is there, you just palpate the pulses, then do the ABI, and still, if you find some confusion, suppose ABI in between 0.89 to 0.7, in that situation, you can go for a Doppler study. But frankly speaking, Doppler study is not of much of importance sometimes.
It's easy to do, it's cheap and much cheaper than an angiography. That's
No,
why
if angio, sir,
to rule out peripheral arterial disease, you get some idea as to whether there is an underlying peripheral arterial
yes,
component to this.
we
ulcer.
do, but if the ABI is less than 0.7, in that situation, patient is going to require a intervention. And believe me, if we are thinking that this patient is going to require intervention, then only we advise for the CT NG of the lower limb arteries. That is done. So this color Doppler of lower limb arteries is a very good tool, but in Calcutta, cost of doing a color Doppler is around 6,000 to 7,000 rupees, and doing a angiography is around 14,000. So sometime I skip.
You can cut it down by doing just one limb, the affected limb. And secondly, just a role of MRI in looking at the joints and the bones of the foot, where there is no. Is there any role for
Yeah.
MRI?
Actually, only in case of Charcot's foot, where there is a strong suspicion, but you are not finding, because X-ray changes will occur after 2 weeks or 3 weeks. In initial stage, X-ray may be normal. So in that situation, and to differentiate sometimes between osteomyelitis and Charcot's foot, we go for MRI. MRI is a very important tool and is a diagnostic for the osteomyelitis and the Charcot's also. We do.
Finally, this is not a question. This is from my experience in dealing with these diabetic foot ulcers. I find the use of acronym PEDIS, PEDIS,
Yes.
in evaluating the ulcer very helpful. So P stands for perfusion, E for extent of the ulcer, D for depth of the ulcer, which you determine with probing, I for infection, and S for sensation. So
PEDIS
this is a very good clinical
classification.
thing to remember.
Yeah, PEDIS, you are using Wagner's, you are using University of Texas, you are using PEDIS. So you can use the Sinbad classification, whatever you well versed with this. But the most commonly used is the this Wagner's, because it's very simple, very simple. Wagner's: superficial ulcer, deep ulcer, osteomyelitis, localized gangrene, extensive gangrene. Very simple. But of course, it doesn't give the clue for the vascularity. So it's incomplete. And nowadays, the most important classification is Wi-Fi classification.
Thank you, sir. Before we ask the audience, I just want to know, as a physician treating diabetes, when is the time when you think it is a time to refer to surgeons? Because we both are here. When do you take a decision that after seeing a foot, you feel it is time to refer the case to a surgical consultation?
If a patient requires debridement, I'll not say debridement, I'll say foot exploration. At that time, if patient having moderate infection, in the mild infection, you may continue with the antibiotics and the dressing, the other thing. If it is a moderate infection or severe infection, straightforward, you have to refer it to the surgeon. And definitely surgical debridement, or I'll call it the foot exploration, is mandatory in these patients, and it's a teamwork. It's not the surgeon going to treat, or diabetologist or physician or endocrinologist to going to treat, or vascular surgeon or orthopedic surgeon. It's a teamwork. Because as I told, I've got 14 members in my team. So we all are dealing with this. If you'll say, Dr. Goel will treat, no, I'm never able to treat the diabetic foot. Because this, you see, amputation and then the closure, everything has been to be done by the surgeon. So if it is a moderate infection, patient requires foot exploration or debridement, you have to immediately refer to the surgeon.
Thing is, house is open. Anybody wants to ask any questions, please? Anybody has, yeah, please, sir, come. Dr. Shubhadeep Paramanik.
Thank you, sir. Excellent presentation as once again. I actually had few questions in mind. I already got the answers. But one thing that after revascularization for an ischemic ulcer, you said we should not stop the antiplatelets. So patient is getting aspirin, patient is getting clopidogrel, maybe rivaroxaban as well. So how often our surgeons are very confident about doing surgery in this scenario, doing the amputation?
Can I answer?
Yeah.
No, because as you know, already we have done the angioplasty in this. Even sometimes we had it discussed, because we discuss the cases. Each time we discuss, because surgeons, especially plastic surgeons, apply a tourniquet to prevent the bleeding. And we say, don't apply tourniquet if patient is in peripheral vascular disease or patient is having angioplasty has been done. In that situation, that is there. And as you have done the angioplasty around 3 days or 4 days back, so in that situation, you cannot start the antiplatelet. Only thing is, sometimes what we do, if we find patient is high risk for bleeding, elderly patient. Recently, we had a 90 years patient in which we have done the angioplasty. Family members were ready. The doctor, whatever you want, you do. And after that, we have done the amputation, the forefoot amputation, and they agreed for that. In that situation, I continue with just aspirin. I stopped rivaroxaban, I stopped the silastazole, but generally the recommendation is the rivaroxaban and aspirin. Even sometimes with the high risk and very great sort of blockage, then we give all three. So in that situation, we don't stop.
Yes, I would agree with that. Minor amputations actually don't require stopping of aspirin or even clopidogrel. If you are amputating a toe in a diabetic foot, you don't need to stop the ecosprin or the clopidogrel.
Because it is not a abdomen where you are not able to see the bleeding. Because here, it's everything is open. You can see the bleeding. It's there or not. That is there.
Right. And sir, while offloading, what I find most difficult is the mid-foot offloading, because front foot we have half sole for posterior half sole, anterior half sole, but mid-foot you have nicely shown the indigenous method that you are using. So, what is the usual recommendation other than yours one? In the guidelines, I couldn't actually find that for mid-foot neuropathic ulcer, apart from TCC, what other option we have for offloading?
About the midfoot ulcer, one is the total contact cast we have shown.
Yes,
then you can have offloading indigenous. Two, suppose this midfoot ulcer is there, you can put one offloading here, one here. That is known as foam offloadings. Then by that you can offload, or you can have the footwears.
Footwears. Okay.
In which there is a midfoot, there is a lot of there is no pressure here. There is a this outer sole here, outer sole will be here, and in the midfoot there will be no outer sole. So
we scoop out the middle part of the sole and we give a footwear. So in our usual practice, for every patient, we do an ABI, we do VPT, and if there is discernible foot deformity, I do a foot scan for each and every diabetic patient, at least once in a year. When we do the foot scan, many of our patients who often do not have very high amount of neuropathy, they still do have some pressure point, maybe in the great toe, sometimes in the heel area. So do you recommend giving a customized footwear for all of them?
Actually, if a patient who is in foot deformity or previous history of amputation, or that patient require customized. So hardly 5% of the patient require customized footwear. Rest of that will be diabetic foot footwear will be suffice in these patients. One is preventive footwear, then the diabetic footwear or the therapeutic footwear, and another is customized. Customized required hardly even 5%. Suppose there is a great toe amputation, then you require customize. If something abnormal in the heel or in the midfoot, then you require the customize. So customization is hardly 5%. Others is therapeutic or preventive footwear. So there are three types of footwear: preventive, therapeutic, and customized. So customized hardly 5%.
And so what is the difference between preventive and therapeutic? The difference between whom to
About the
prescribe?
preventive, if you have got neuropathy, you have got loss of protective sensation, in that situation, you use the preventive footwears.
Okay.
And in case of therapeutic, if you have got ulcer or something else, then it's therapeutic. And if
Okay.
customized, if there is some deformity in the
We are actually running quite
Okay.
late. Let's
Thank you.
conclude the session and thank you once again, Dr. Goyal.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir. Sir, thank you.
Thank you, Dr. Ghanshyam Goyal, sir, on this wonderful session. I would like to request Dr. Kaushik Bhattacharya, sir, to felicitate Dr. Ghanshyam Goyal, sir. And I would like to request Dr. Ghanshyam Goyal, sir, to felicitate Dr. Soumitra Shah, sir, and Dr. Kaushik Bhattacharya, sir. Thank you. Thank you so much, sir. Our next topic of discussion will be Finerenone, the new player in CKD. Moderator for this session will be Dr. Shekhar Chakravarti, sir, and the speaker will be Dr. Vishal Gole, sir. I would like to request Dr. Shekhar Chakravarti, sir, and Dr. Vishal Gole, sir, to please come up on the stage. I would like to request our chairperson, Dr. Shekhar Chakravarti, sir, to please introduce the speaker, Dr. Vishal Gole, sir.
Good evening to all of you. I think now the most of the chairs are empty. This is a very important topic.
I would request our delegates to please settle down. I would like to request our delegates to
So
please settle down, sir.
today, this is a important topic will be delivered by Dr. Vishal Gole. He's a very renowned nephrologist in this part of the country. He doesn't need detailed introduction. He's known to all of us. Dr. Goyal will speak on important molecule. You all know Finerenone and what is importance, where to use, and it's related this. Then followed by we'll have a panel discussion. Okay, over to Dr. Goyal.
Okay, thank you, Chairperson. Thank you, Dr. Arundhati, for inviting me for the talk. Now, since this usually happens that in any multidisciplinary talk, the nephrologists are usually pushed behind between the last of the presentation and the spirited things that happen in the cocktail dinner. And most of the time we tend to skip our slides because what we have to tell doesn't add much to the overall treatment data. But now, since the last 2 years, we have a few molecules because of which the nephrologists will be able to contribute academically, and probably those who are left behind to hear the talk might benefit from what we have to talk about. So the topic for today's discussion is on Finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. And what role does it have on the renal outcomes and the cardiovascular outcomes? So for a very long time, the diabetic nephropathy and CKD was a very disastrous thing to happen to the patient as well as to the doctors, because for a long time we didn't have much therapy. Most of these patients ended up in dialysis, and even on dialysis also initially there were not many therapies. So many of these patients were transfusion dependent, and they eventually died out because of the disease. But for the last couple of decades, we have very good molecules starting from the ARBs and AC inhibitors, because of which there was benefit in mortality and long-term survival. And again, for another many years, there was a long lag, after which we had good molecules like the SGLT2 inhibitors, which came a couple of years back. And now we have a new molecule which can add to the treatment, and it can have a significant impact on the overall mortality as well as the morbidity benefits in this group of patients. So I have actually included the slides given by Bayer, because when I was making the slides, I found out that the slides which Bayer had made for this study are very good. So I didn't feel like changing them because they're very good, and it will make my talk much easier. Change what channel? So we all know that so we all know about the burden of diabetes. I think enough talk has been already done about this. Only thing to keep in mind is that around 40% of patients with type 2 diabetes eventually end up having some sort of diabetic kidney disease. And a lot of them progress on to end-stage kidney disease, and it contributes to death. If a patient has type 2 diabetes as well as chronic kidney disease, the cardiovascular mortality in these patients is around 6-fold, and when we compare it to the normal population. So it has that much bearing on the overall survival of patients. So if they have both of them, so the mortality is much higher than if they are in a general population. There are two things to be taken into account when we manage patients with chronic kidney disease, especially if they have diabetes. The usually forgotten one is the albuminuria. So it's always recommended to measure albumin excretion in the first visit of this patient, because it has direct correlation to the overall mortality. If the urine albumin creatinine ratio increases to a higher range, the mortality increases in this patient. CV mortality, and it also correlates with the fall of GFR. So these two factors are acting independent of each other. If you look at the various studies that were conducted, one of the important slides that we all have been seeing in CKD patients is the impact of both a fall in GFR as well as gradually rising albumin concentration. So we know that as the GFR falls, the overall cardiovascular mortality rate starts increasing as the GFR falls to less than 15. And the albumin concentration also, as it goes up, it contributes further to the cardiovascular mortality. So the worst group of patients are those who have a very low GFR and they have a very high albumin excretion. But albumin excretion independently of GFR also, it contributes much higher to cardiovascular mortality. So this thing is to be taken into account whenever we are treating patients with diabetes. So how do we screen them? We screen them according to various guidelines based on across diabetes and the other cardiovascular bodies, as well as our KDIGO guidelines. That we recommend that patients should have a urine albumin creatinine ratio measurement and GFR on baseline. And depending on the baseline parameters, they have to be monitored either yearly or more frequently, depending on whether they have high creatinine, or if the albumin creatinine ratio was high on the baseline. So the baseline variable of these two things, they have a direct impact on long-term survival. So how is CKD progression driven by the various things that happen in patients with diabetes? So the most important factor that we know are the hemodynamic changes, the elevated blood pressure, high blood pressure, as well as the intraglomerular hemodynamic changes. They contribute to CKD progression. And the other factor is the metabolic factor in the form of very poor glycemic control, which itself So none of these factors generally tend to occur in singularity. All of them are correlated, but these are the basic three things that happens. And all of them progress leads to damage of the four components of the kidney, and then it leads to CKD progression. So there are drugs which act on the hemodynamic part, the blood pressure part, the lowering of blood pressure. We know that good drugs like the ACE inhibitors, ARBs, and even the SGLT2 inhibitors also acts partly by lowering the blood pressure. On the metabolic part, again, there are good molecules, especially the control of glycemia. And among them, there are again good drugs. Again, the SGLT2 inhibitors comes higher in the list now. But the third component of inflammation and fibrosis was not addressed till now. So they were looking for targets on how to control inflammation and fibrosis. There were a lot of anti-fibrotic molecules which have been tried in the last many years, but none of them had any positive impact on preventing CKD progression. And this is where the new drug comes in. And we know that even though there are good trials like the renal trial or the identity trial where the composite primary endpoint of doubling of creatinine, SKD, etc., was shown to be significantly better with losartan or ARBs and ACE inhibitors in some of the other trials, as well as when they added on SGLT2 inhibitors, although they had a benefit on the overall outcomes, cardiovascular as well as renal outcomes, but there was a progression of CKD in this patient in all these groups. So there was no therapy which tended to either slow down the progression or reverse the progression. So this was a very frustrating thing that was happening in CKD management. Change. Change হচ্ছে না তো? So we now come to finerenone. So what is finerenone? It is basically a non-steroidal selective mineralocorticoid receptor antagonist. We already had a steroidal mineralocorticoid receptor antagonist already in place, the spironolactone and eplerenone. So the steroids, they usually have a very good large molecule of a ring of steroid, which is basically the cyclopentanoperhydrophenanthrin ring. So the finerenone is not a steroidal drug. So it is basically, its structure is very much similar to the dihydropyridine. So because of which the specificity of binding to mineralocorticoid receptors, which are located primarily in the kidney and in the cardiac muscles, they are very specific. So this is the benefit of finerenone. And the downstream of the expression of these molecule is that once the mineralocorticoid receptors bind with the mineralocorticoid, it triggers a downstream pathway and eventually leads to expression of genes which causes an effect on the fibrosis and progression of fibrosis and inflammation. So the basic this mechanism is being blocked by the use of this drug. So this is the basic concept with which these molecules work. And if you look at comparison with other aldosterone antagonists, the finerenone is basically more specific. The potency against mineralocorticoid receptor is high. The specificity is high because of its structure, because of which the side effects like the sexual side effects and the effects on gynecomastia, as well as even the potassium hyperkalemia is much lesser with finerenone. So with this benefits, this molecule was tried in 2 large trials, which we will be discussing next. So coming to the main topic of discussion today, we will discuss about the 2 large trials which were published using finerenone as the basic molecule. These 2 trials are probably the largest trials conducted in diabetic kidney patients. Even the amount of patients included in this trial are much larger than the other trials published before. So this is possibly the largest trial up to date on, especially in the nephrology population. So one of these trial is the Fidelio DKD trial and other is the Figaro DKD trial. These are both named on basis of some opera performances. So this is an acronym of that trial. So basically they use finerenone in one arm, both of them, 10 milligram or 20 milligram, depending on the baseline GFR of patients, and the other arm was placebo. So both of these trials were double-blinded, randomized, placebo-controlled trials. So in one of these trials, the Fidelio trial, it was primarily based on studying the kidney endpoints. So the primary clinical endpoint was the composite endpoint of time to onset of kidney failure in the form of onset of dialysis or sustained decrease in GFR of more than 50%, or primary death due to kidney disease, which happened before the patient ended up in kidney failure. So this was a primary clinical endpoint in Fidelio DKD. However, the Figaro DKD trial primarily was a cardiovascular composite endpoint study. The primary study endpoint was a composite of the 4-point MACE, the CV death, non-fatal MI, non-fatal stroke, and hospitalization due to heart failure. Now, these two trials had switched their secondary endpoints. So the secondary endpoint for Fidelio DKD became the primary endpoint of Figaro DKD. So basically, they swapped their primary and secondary endpoints. They also had other endpoints which they had studied, in which there was a change in urine albumin creatinine ratio from baseline, all-cause mortality, all-cause hospitalization, and also a sustained decline in GFR more than 57% from baseline. So basically, this value is taken as doubling of creatinine. So if you look at the doubling of creatinine and calculate them according to GFR, so the fall of GFR will be around 57%. So this was mainly done to make sure that the trial data is comparable to the previous published trial where the kidney endpoint was doubling of creatinine, like the renal and the IDNT and all those things. Okay, so the Fidelio DKD study design, they included patients who had type 2 diabetes and CKD with a urine albumin creatinine ratio of around 30 to 300 with a GFR between 25 to less than 60. But they needed to have a history of diabetic retinopathy as the inclusion criteria, because this was a patient with not much significant proteinuria. So they included diabetic retinopathy as one of the important inclusion factors in this group of patients. The other group of patients were those who had microalbuminuria, the previously told microalbuminuria, more than 300 to less than 500, and a GFR range of 25 to 75. So pretty much a bad group of patients with CKD stage 3, predominantly stage 3, 3A, 3B, and 4. And all these patients had been treated by adequate doses of ACE inhibitors or ARBs at maximal tolerated dose to be included in the trial. And since hyperkalemia was the concern, so a potassium of less than 4 was the inclusion criteria. So they basically included this group of patients in the Fidelio DKD trial. And the exclusion criteria, the predominant important exclusion criteria which they have considered is the patients with chronic symptomatic HFrEF, because they could not include patients with this and not give them spironolactone, because again, there is a problem with the class Wiener criteria for treatment of HFrEF. So they had to be excluded. So after a screening period of around 2 weeks, so they were randomized into, so basically they were fully covered with ARBs, ACE inhibitors, and they had to be run out of all the other drugs which they were taking. So if, should we continue? Because this is quite bad. Anyway, so they had randomized them into receiving finerenone and placebo, and the trial duration was planned as this much. However, they actually studied up to 2.6 years in this study. So after that, they were given a dose of 10 milligram of finerenone if the GFR was less than 60, and if it was more than 60, then they have given a dose of 20, and they had titrated it later on. So coming to the study design of Figaro, now this interesting thing in this inclusion criteria is that they had included patients with a more lesser severity of CKD. Up to a GFR of 90 was included in this patient. They did not have retinopathy in the screening, and they also included patients with a lower GFR. But again, interestingly, turned out that many of these patients included in this trial did not have that severe CKD. So it was a more open type of study in which more number of patients were studied, because this was primarily studied as an endpoint on cardiovascular mortality rather than renal outcomes. Again, chronic symptomatic HFrEF was excluded, and they had a similar trial design, and the randomization was the same. So again, as I had already told, if we included these two trials together, the finerenone-based trials are probably the largest trials conducted to date on CKD population. So this is a very good data set, and whatever came out of these trials have a good impact on our clinical practice. Only thing that is taken to be taken with a pinch of salt is that they were both sponsored by Bayer. So this is an industry sponsored trial. So, but in any case, since the number of centers and the number of patients are quite high, and the way in which the trial was conducted was quite robust, so we can take these trials with confidence. So baseline characteristics of these patients are quite similar. So a little older group of patients, the blood pressure was pretty much well controlled with the ACE inhibitors and ARBs and other drugs. Some of them had been taken diuretics also. The potassium was comparable in this group. So this was pretty much comparable groups in both the two sets of patients. Again, in this case also, these are pretty much comparable. So not much difference in both the two studies. So interesting thing that I was telling was that in Fidelio, we had more number of patients with lower GFR. So this was primarily aimed at studying the kidney outcome, and we had a lot of patients with a lower GFR. So we can see what happens to these patients when we are giving them drugs to study the kidney outcomes. Whereas, as expected in Figaro, they had much lesser severe CKD patients. Many of them did not even have CKD according to the classical CKD definitions. Many of these patients had more than 60 ml GFR, which does not fall categorically into the definition of CKD. Again, in the albumin creatinine ratio excretion part, the lower excretion ratio with pretty much non-albuminic patients were not included in both these trials. Since we do not know what happened to these patients, and since the trial duration was short, so there was no point in taking this lower albumin patients. So there were a good number of patients with high albumin excretion. So again, around 99% of patients in both the arms were receiving either ACE inhibitors or ARBs. So they are pretty much well-treated patients according to the current guidelines. Since the SGLT2 inhibitors were just coming in the market at that time, there were significant number of, few number of patients in both arms who were taking SGLT2 inhibitors. Now, since this drug independently was found by the EMPA kidney and the DAPA-CKD trial to have impact on cardiovascular and renal outcomes, so it is interesting to note whether these drugs, they act combined, whether they act well or not. So initially there was some sort of comment on whether giving mineralocorticoid receptor antagonist on ASE inhibitors and ARBs are useful or not, because previously few trials were published, like the Altitude trial and the VA trial, where combining both the RAS blockades had actually found to be worse, because they used to cause higher amount of AKI and the hyperkalemia rate was more. So they were quite skeptical whether it would be the same in this trial, but they had pumped in a lot of money. Unfortunately, that did not happen. Otherwise, they would have lost a lot of money on this trial. So again, the mean follow-up eventually came to be around 2.6 years for Fidelio and 3.4 for Figaro. So as I had told, and adherence to the treatment was quite high, as it was not expected, because the expectation was that many of the patients would be dropped out because of high potassium and rise in creatinine because of the RAS blockade, which happened almost like a double RAS blockade. But fortunately, there was very high adherence to treatment. So the end of trial, the number of patients that were left for comparison was quite high in both the studies. So the efficacy and safety outcomes. So when they added this in the Fidelio DKD trial as the primary kidney outcome study, this were the primary kidney outcome parameters that were considered. And after a period of 1 year, the benefits started accruing in the Finerenone arm. So at the end of the trial, the hazard ratio came to be around 0.82, and the Finerenone did have a cumulative lowering of the kidney endpoint by approximately around 18%. So the numbers needed to treat, that means a number of patients needed to treat to prevent one of these events was 29 in this trial. So this is quite good. And this is in addition to the ACE inhibitors and ARB that this patient was taking, which probably is an additive factor on top of ACE inhibitor and ARB therapy. So This is a very good finding. And if you look at the forest diagram, the kidney failure, although many of these parameters were crossing the central line, but the overall final primary composite endpoint tended to favor towards finerenone. That is, it was significant. And again, the change in urine albumin creatinine ratio, which was one of the study parameters studied, also showed that finerenone lowered the urine albumin creatinine ratio. We know that lowering of uric ratio tends to cause an impact on the overall cardiovascular mortality. So although that was not the thing that was studied, so we can extrapolate from this data as well. And the secondary kidney endpoint, again, which was a not so severe worsening of kidney failure, even that one was lower with finerenone, but it was not a significant finding. But anyway, that was not the primary thing that was studied in this trial, but it showed a favor towards finerenone. So again, in the fidelio-decade, the secondary CV endpoint was a lowering of the overall CV endpoints by 14% when compared to placebo. Again, this was a statistically significant finding with a p-value of 0.03. And again, the numbers needed to treat for reducing the cardiovascular endpoint was 42. So again, this was quite good when it was considered on top of the fully supervised therapy of ACE inhibitors and ARBs. Now, looking at the Figaro, the similar type of finding was seen in both the primary cardiovascular endpoints by lowering of primary cardiovascular endpoints by 13% versus placebo, which was again significant. The numbers needed to treat again became 47 for Figaro. And looking at the renal outcome also, a similar type of finding was there, but this was not significant in the Figaro study. But if you look at the primarily when they looked at only the kidney failure parameters and doubling of creatinine or renal death, which was the other things that were studied in the kidney outcomes, that became significant. So we can argue that the number of patients used in Figaro trial did not have a very advanced CKD. So maybe this benefit is not that significant because the CKD population was in earlier CKD, but they had pooled both the data of the Fidelio trial and Figaro in a second pre-specified composite endpoint study, which is known as the Fidelity, which I'll discuss a few slides. And they pooled both the data and found out that this had some impact in the overall pool data. So I will skip all the slides. So this Fidelity is basically a pooled pre-specified analysis of data which was taken from Fidelio-DKD as well as the Figaro-DKD trial. The total number of patients pooled for this study was around 13,000 plus, and the same sort of randomization as it was the same study that was included in this publication. So this remains the same. The pool data included all these patients. Some of these patients with higher GFRs of more than 90 were from the Figaro group, and the lower GFR was from the Fidelity group. Those with lower urine albumin creatinine ratio were also there in this group, and this was pretty much a good representation of CKD in the higher as well as the lower CKD groups. So they had actually divided these key outcomes into two groups in this publication. There was a CV composite outcome and the kidney outcome. Now, in kidney outcome in this in the pooled analysis was time to kidney failure. Also, they included doubling of creatinine, that is sustained more than 57% increase in GFR, and kidney-related death. And obviously, CV outcomes is the 4-point MACE. So both these parameters were found to be significantly better when the data was pooled. So these are the numbers that came out from this publication, that the CV mortality and morbidity reduced by 14% when finerenone was compared to placebo. This was a statistical significant finding. And also the CKD progression was lowered by 23% when finerenone was compared to placebo. And numbers needed to treat came to 46 and 60 respectively for both the CV outcome as well as the kidney outcome. And another interesting thing in this study was that although the intention to treat primary analysis did not show significance, but when these patients were actually on treatment on both in the trial, so this primary analysis happened, some of them were followed up even after the trial. So the on-treatment analysis means that these patients were analyzed when the patient was actually taking finerenone. So when they were actually on the drug, the cardiovascular mortality as well as morbidity was significantly, especially mortality was better with finerenone. So maybe continuing the treatment with finerenone will add on to this sort of continued mortality benefit in these patients if they were followed up for a longer. So I would like to also point about the SGLT2 inhibitors used in this therapy. If the patient were not on SGLT2 inhibitors in this fidelity analysis, then still the adjusted hazard ratio of benefit was 0.8, that is a 20% benefit. And when the inhibitors were used, then the hazard ratio came to be around 0.45, which is much higher when they were not on SGLT2. Although this was not, it was sort of crossing the midline, but this was not the primary thing that was studied. So we do not know whether adding finerenone to SGLT2 inhibitors actually causes a benefit, because that was not studied in this study. But maybe it might be beneficial when we add both these two groups together. So I think we will probably go to discussion. I think too much of. So we know all these things. I think I will skip all these slides. So what we have to remember is that now we know this diagram from the ADA publication. So the management of glycemic control, blood pressure control, lipid management was always there. And now we have agents with cardiovascular and kidney benefits. The agent which was already existing was the RAS blocking agents. Now we have SGLT2 inhibitors and the non-steroidal mineralocorticoid receptor antagonists, which will act on this part of the diabetic management, especially in preventing cardiovascular and kidney outcomes. So probably that is the thing that should be the take-home message, and we can discuss whoever is left behind.
Thank you, Dr. Vishal, for your excellent presentation on finerenone. So I think now is 10:40. So most of the chairs are empty. So we'll go for a very short panel discussion.
Okay.
Okay, I'll invite Dr. Gaurav and Dr. Ajit and Dr. Pandit come to the dais, please. One chair more, Dr. One chair more. Shall we sit?
So before you start this session, I'll just like to say one thing. The chairs are empty, true. But I'll tell you one story before you start. 3 years back, I had an eye problem suddenly. So, and this is for all the panelists, for whom I'll ask them not to look in that direction, but in each other's. Why, I'll tell you. I had an eye infection, and over a period of 2 days, my vision was limited to hand movement, suddenly. All the top eye surgeons of the city, they had a look. They put me on steroids, they put me on antifungals, they put me on because nothing was working. I was literally going blind. Then I was there was a session going on. They had a board meeting because nobody could decide what was to be done. They were referring me to Hyderabad. One junior doctor, he stood up and said, "Sir, amar mone hocche eta mycoplasma." So they were like, "Mycoplasma amra keu dekhini." So sir, ami ekta session e shunechhilam je erokomi picture lagchilo. And in mycoplasma, basically the steroid was the problem because everybody was putting me on steroid eye drops. So then they said, "Theek ache, let's give it a try." They took off my steroids, and in 3 days, my vision improved and I recovered. Now that doctor, that junior doctor, who was a first-year resident, actually the first year he had joined, he said, "Madam, apni bishwash korben, oi session ta keu shoneni. আমি একা বসে বসে মাইকোপ্লাজমা আই ডিজিজটা শুনেছিলাম and I held his hand and said, "ভাগ্যিস ভাই তুমি শুনেছিলে তাই আজকে আমি দেখতে পাচ্ছি, নাহলে প্র্যাকটিক্যালি আমি দেখতে পেতাম না." So it doesn't matter how many are there in the audience. If even one person takes the take home message, it is important in the life of so many people around. So with that, please start off.
Okay, I would actually ask the people who are waiting outside, then please come inside at least. So
Yes, we will request.
Gole, for your wonderful discussion on. Now we have got number of panelists. So now, first of all, before starting, I would just a basic thing. We'll start and we'll discuss about the phenomenon. This is an important. To the audience, anyone, do you think the CKD is a progressive disease, is a stable disease, or a regressible disease? What is your opinion? To the panelists also. Progressive disease? Stable disease? No. Regressive disease? What is your opinion? One by one, panelists, please. Dr. Ajit. Sure.
First of all, thank you, Dr. Arundhati and Dr. Dev for this diabetes update. I'm just keeping short. And thank you, Dr. Gole, for excellent deliberation on a new molecule, a new hope to treat CKD. So by definition, as sir asked, by definition, CKD is irreversible and progressive disease. So just answer to sir question, and then we all treat CKD in our day-to-day practice. And it's very frustrating to see in diabetic CKD, particularly the today's session related to diabetes. So diabetic CKD progresses more rapidly compared to non-diabetic CKD. So I'm just keeping my discussion brief. And
So I would like to give a, I don't agree with this fact, because initially it was thought that CKD is a progressive disease, especially those who have a higher albumin excretion and lower GFRs, they usually progress. But it is always seen in most of the trials, the sub-hoc analysis, that many of the patients with a lower albumin excretion and the higher GFR categories, many of them do regress. So that is the thing, because there was a publication by George Bakris in, I think in CJASN, I think in CJASN. So he had argued in this fact that these patients should not be pessimistically told about the progression of this disease, because if we are able to catch them early on in a higher GFR category, or with a GFR of around 60 plus, or with the albumin excretion of lower albumin excretion, and if we add them on RAS inhibitors, RAS blockage, and maybe these new drugs, many of these patients will regress. So this is the thing that we have to tell the patients. But once they end up in a lower category like GFR, maybe 3, 4, or albumin excretion is much higher on baseline, these patients will progress. So it is this.
What is your opinion, Dr. Gaurav?
Sir, as we know, sir, so I would like to conclude both my seniors telling like a correct thing, because like we often tend to write nowadays like stable kidney function, CKD with stabilized kidney function. So, sir, I'm agreeing with both of my seniors. By definition, it's true, sir. Like we always say, once you are a CKD, it will always progress. But yes, sir, in my, when, as sir said, like we studied in such an institute where we had all that rat models and all the things which had been in research things. So yes, it's true, sir. Once we catch a CKD patient who is in early stages, like in stage 1 or 2 or something, or has only albinuria, which is not macroalbinuria. So on that stage, if you catch
so
them,
you agree that it is a
Yeah,
reversible
sir.
disease, Dr.
Reversible,
Demnath?
like, sir, if you catch early and
Yes,
not
yes,
not
that's
much,
true.
it goes back.
Hello. Progression of CKD depends at what stage patients are coming. In initial stages with higher GFR, some extent this is stable, but on the later part of GFR, especially with diabetic patients, many times patients are adequately treated with antihypertensive and anti-diabetic. Still, we see that albumin creat ratio is increasing, GFR is declining. So, in spite of doing all these things, 30% patients progress to CKD. So, in these patients, I think this type of new molecules can be a miracle.
Okay, fine. So you are in the opinion that it is a progressive disease.
Yes, in some
Sir,
patients.
Pandit.
Sir, It is a progressive disease and the rapidity of progression depends upon the urine ACR level. If it is very high at the time of presentation and the GFR is low, then the rapidity of progression is very high. To some extent, we can say that it is a stable CKD if you maintain the patient on minimum molecules and there is no acute on chronic onset acute event.
So in nutshell, we can say that what Dr. Gole has rightly said, that some of the patients, all CKDs are not same. It is a heterogeneous group of disease. There are some CKDs are there who are progressive. Some CKDs are there who are stable for a pretty long time. There are some CKDs with intervention can regress. So I'll come to the point. So now the thing is that is the heterogeneous group of disease. There is also heterogeneity on the etiology also, as well as the nature of the disease. So why you call it a progressive? And before going to the progressive disease, because I come to the phenomenon in this point of time, what is the normal decline of a GFR of a person? Normal decline. So, whatever you do, you don't do. A normal healthy person who is aging over the period of time without any disease of the kidney is bound to decline its GFR. And what is the normal rate?
After the age of 40, 1 ml per year.
Yes. So it is commonly think that at the age of 20, we have got a maximum GFR of 120 like this. And then after that, there is decline of 1 ml per year and leading up coming to at the age of 70, it becomes 70. This is the usual standard guideline that at the age of 70, the GFR is 70. If a person has got a 70 GFR, this is the age-related decline. This is the thing. This we cannot change because this is the normal thing which is happening in our body. Now, on the top of this, we have got a many disease, heterogeneous disease, many etiology. So on the top of that, our GFR is gradually declining because of the disease process. But without disease process, there is also, so in one sense, that what is happening, the declining GFR is not called CKD because this amount of GFR usually are very little we can identify in our clinical practice. But actually it is also CKD because there is reductions of the GFR because this is the 70 is between 60 to 90, which is basically the grade 2 disease. So therefore, we are having the CKD. In one sense, it is certainly progressive. In the other sense, it is the disease which might regress. Now, what Dr. Gole has rightly said, if we can pick up the patients in the early, and if we pick up the patients in early albuminuria, say less than 300, which we used to call it in macroalbuminuria, and also it's a very early decline in GFR. In fact, we can make some regression of the disease towards normal. Now, I'd ask the panelists that we have got the CKD, two major groups. One is diabetic and another is non-diabetic. Do you find any difference of its pathology and on its onset of the disease?
CKD progression, we can divide into 3 trigger factors. One is hemodynamic level, another is metabolic level, and another is interstitial fibrosis or tubular atrophy.
Due to inflammation.
Yes, inflammation.
Mostly.
Inflammation. So depends on pathophysiology, depends what type of mechanism is involved. In diabetic patient, we know that there is a Mogensen classification. This is based on type 1 diabetes patient. The first stage was increased GFR in hyperfiltration. So this is the first trigger point. That if intraglomerular pressure is increased, so if chronically this happens, ultimately this will result.
So hemodynamic factor comes first.
Yeah, this is hemodynamic mechanism. So in hemodynamic mechanism, what are the armamentarium we have? SCRB and SGLT2 inhibitor, GLP-1 analog.
No, I'm not coming to the point. The main important point, I guess, Doctor.
Let me tell this. I think what sir is asking is that how does a kidney disease start? Basically in different type of diseases. So eventually the boiling pot in CKD is that eventually there is only one thing that happens, and there is a global fibrosis of all the compartments of the kidney, the glomerulus, the interstitium, the tubules, and the vessels. But many of the time, the origin is usually from one of these four components. Like for example, in nephritis, glomerulonephritis, the primary problem starts from the glomerulus. After that, because of the filtration and because of other things, the tubules get damaged. Then the interstitium get damaged. Then they have hypertension. Then they have arteriosclerosis, and eventually
Right,
there's a
right.
global
The
fibrosis.
thing, what Dr. Devnath was trying to say, in the diabetic patients, the three factors play. There is to start with an hemodynamic abnormality associated with metabolic problem, which is going with the metabolism, and also inflammation. Diabetes is an inflammatory disease. So these three components are playing in case of DKD, diabetic kidney disease. But these three components may not be present in all case of DKD. I mean CKD. Say for example, there are some CKDs where hemodynamic factor doesn't play. Only there is inflammation and the metabolic problems. So therefore, diabetic kidney disease is the one of the worst kidney disease where the three major pathological processes were to play. And that's why the diabetic kidney disease was, Dr. Was trying to say that this is the, among the all CKDs, probably the diabetes, so far the onset, its progression and its management is the most vulnerable group of disease population, because all these three pathological processes. And probably for this reason, these group of patients have been included in this trial. Because you need, if you see that Figaro trial and Fidelity trial, I mean Fidelio trial, this you see only the diabetic kidney disease are included. No other kidney disease are included. Only these patients are the diabetic disease. Because diabetes is an inflammatory disease, and what we want to establish a drug which is basically an anti-inflammatory, anti-fibrotic. So without any question, any debate, we can recruit all these patients as a drug which is applicable in the drug. Finerenone in later one might have any, in future might have any other trial of a non-diabetic kidney disease, CKD. But right now, it is a drug which has been studied in the diabetic population.
So have no studies been done in non-diabetic population for finerenone at all?
No. The inclusive criteria was
In
done.
these two trials it was, but has till date no trial been done in non-diabetic kidney disease?
Only
Why is that so?
Before finerenone, anti-fibrotic agent pirfenidone was used, but the study result was not satisfactory. I can
So
say
why
the
do you
details of
suppose they
that
took
project.
only the diabetic kidney disease patient, whereas fibrosis is a matter of concern in a lot of other kidney disease also? So why
Actually,
exclusive?
if you look at the way in which the finerenone trial developed, so initially they looked back at the eplerenone and spironolactone initially. So there were few trials on this, especially in cardiovascular outcome trials. So there they had benefit in lowering of albuminuria. That's why mineralocorticoid receptor antagonists form one of the ways in which albuminuria is reduced. So if the patient's proteinuria is not reducing, then if you add ARBs, INIS inhibitors, and other drugs, CCBs, then we tend to add mineralocorticoid receptor antagonists as one of the drugs which lowers albuminuria. This was drawn from these trials which was done on spironolactone and eplerenone. So later on,
I'm really interested in understanding why only the, like even SGLT2 inhibitors, we are looking at the non-diabetic.
they would not have got a clinical trial clearance if they had not included diabetic kidney. That's what I was talking about. Because
why only diabetic kidney? Are we not expecting results in the non-diabetic kidney disease groups?
ideally they should, because if you look at the way in which finerenone works, it acts on the downstream the regulation of the genes which causes fibrosis. So most of the kidney diseases eventually end up in going through the same pathway of disease. So the RSC1 pathway is the main one which acts in this. They go and binds the receptors and they triggers translation of proteins which causes RNA and the mRNAs which causes expression of genes which causes fibrosis. So if you look at that, finerenone should be working in other group of patients also, since they have not been tried. So maybe if they design another trial in which they, just like the DAPA-CKD and the DAPA-HF trials, where many of them did not have CKD, if we do trials in cardiovascular outcome trials, predominantly cardiovascular outcome trials, not including diabetic patients, maybe there might be a benefit. But since we do not know, so right now there is no FDA approval for using finerenone in non-diabetic CKD patients as of now.
So correct me if I'm wrong, what I understood from the inclusion criteria. So one group was the albuminuria group, whose GFR was maintained. The other group was the low GFR group where albuminuria was not much. Is that the true
Not
division of
exactly
the-
low
Urea was present in both the groups.
No, like 30 to
And
300.
in one group, there was low GFR patient, another group high GFR. All these patients were diabetic kidney disease.
So all these groups had had albuminuria,
Yeah.
and one group had low GFR, one group had high GFR.
High GFR.
Now,
Okay,
basically,
like not high, but as in like high,
I mean,
25 to
low
60,
GFR.
20 to 60.
Still, the drug is indicated up till 25 GFR.
The
only.
lowest they've seen is up till 25.
25. The normal dose 20 milligram, more than 60 GFR, and 60 to 25, 10 milligram.
Okay.
But there was a Sawbuck analysis of Fidelio and Figaro also, especially in the fidelity Sawbuck analysis there, when they had actually included this patient in the trial, and they had a GFR of more than the 25. So, but when the trial actually started, this patient had a drop in the GFR. So there was a small subgroup of patients where the GFR came down to 15 also when they had studied the trial. So these patients also had similar benefits as was shown in the trial population. Since they were not included in the trial population, so they could not publish the data. But the analysis of these patients showed that finerenone was still working in the same way in patients whose GFR was between 15 to 25 also. So this is a very big thing to be explored, because small number of patients might not be giving, they will not get a FDA approval based on that small group of patients. But if they conduct a trial just like the DAPA trial, where they included a lower GFR or the EMPA kidney outcome with a lower GFR, maybe the benefits will go to a lower GFR also. So
in fact,
some
the thing is that fidelity trial, which was the later on, is a pool data. Actual trial hasn't been run is Figaro and Fidelio. These two trial has been conducted, and the fidelity is the pool data from these two. In fact, if you look carefully, that these trial initially they have got the proteinuria. When they thought that I'll put this in such a fashion that the fidelity will go to Figaro and Figaro will go to, Fidelio, then they divided these two groups. One has gotten proteinuria between 30 to 300, and other groups is 300 to 5,000. This was not initially the criteria. Initially criteria was that whatever the proteinuria will include it. But when they have decided that, okay, well, these two groups will compare, we'll separate this group and we'll put this pool data in a fidelity trial, which was a larger composite trial of both these two trials, which is one side is a cardiovascular trial and another is the renal trial. Then they divided these two groups, and they actually exchanged this group between these two. That was done later on.
yeah, if you look at the Figaro trial also, if answering to your question, because I think that will be interesting for you, because if you look at the fidelity trial, the Fidelio trial, their main goal was to include patients who had classical diabetic kidney disease, because they included patients with diabetic retinopathy in those who had a lower albuminuria, to make sure that they were including only diabetic nephropathy patients. Whereas in Figaro, they removed the diabetic retinopathy part, though it is quite possible that a significant number of patients who had CKD in that group might not be diabetic CKDs. It could be primary CKDs because of some other cause, because they did not include that retinopathy part, and they were quite liberal with the GFR criteria. So we do not know that.
Taking a cue from your questions, that classic learning that we had, that retinopathy, and does it exist in practice? Do you see it
Yeah,
exist?
around 70 to 80% is there in type 2
I'm
diabetes.
not seeing it. I have so many retinopathy patients who barely have albuminuria, or vice versa. I mean, there are so many. I mean, we could pull the data now that we are keeping the data and all that.
No, that is something I was also
data-
thinking. Can I?
Experience is just opposite. So if we have albuminuria, and then we go for screening for retinopathy, and if there is retinopathy, then we consider it as a diabetic kidney disease.
So in that
In fact,
case,
so
there are
that-
so many patients who have retinopathy, but they do not have
Yeah,
albuminuria.
that can be true.
Or
But
No,
if the
that-
patient
so what you're
is
saying is,
having
if the patient is
albuminuria,
albuminuria and no
then
retinopathy,
retinopathy is there, then we consider it.
so if I have a diabetic patient with albuminuria and no retinopathy, I'll think in terms of non-diabetic kidney disease.
Yeah.
Ma'am, in general,
We can go, but
Now, can I put one thing, please? In some patients, those who are not having proteinuria, but developing DKD, diabetic kidney disease, there is a subset of patient. We never have microalbuminuria or albuminuria. In these trials, those patients are not addressed, I think.
And absolutely true, because the GFR decline and GFR and proteinuria are two separate entities. Not that those patients who are having the decline in GFR must have the proteinuria, not that. It might, we have seen the patient that there is decline in GFR, even in the GFR ESRD level, there is no proteinuria. Sometimes there is a massive proteinuria. Say, for example, nephrotic syndrome, the diabetic patient is developing secondary nephrotic syndrome. You'll find the patient has got a frank proteinuria, but the GFR is absolutely normal. So these two are the absolutely different entities. They are merging. So you will see the guideline that there is in one side is the glomerular filtration rate, another side is the albuminuria. They are trying to merge these two of the different categories, but not that which is the driving for the proteinuria, which is driving for the GFR has been meticulously controlled by the kidney. So therefore, it is not synonymous. It is not matching with each other. It is matching, but not necessarily matching it everywhere. And in fact, as responding to Dr. Arundhati's statement that this is a standard teaching is that the patient who are having retinopathy, I mean diabetic retinopathy, are almost always having the nephropathy. Nephropathy doesn't mean that the patient will have retinopathy.
That is what I'm saying together, that we see a lot of patients with retinopathy and no albuminuria, no rise, no fall in GFR. Yes, also, so that is, I think, I want to talk to the nephrologist.
There are the other causes of retinopathy as well, which may not be guided by the diabetic.
I'll let you know what you want to ask, ma'am. Like, see, like a patient diabetic, ठीक है, आपको उसको diabetic nephropathy stamp करना है. तो आप उसमें क्या-क्या देखेंगे? Proteinuria, hypertension, and you see retinopathy. If you have retinopathy, तो आप stamp कर दिए.
That is what I'm saying. In practice, we are not seeing. Obviously, the patients that you are seeing are already the ones who are getting a high creatinine, right? Or but the patients that we are seeing, हम लोग जो patient देख रहे हैं, बहुत patients ऐसे देख रहे हैं जिनको retinopathy है, but ना albuminuria है, ना fall in GFR है.
ऐसा है ना, अगर उसको retinopathy है, मैम, और वो उसको आप diabetic nephropathy conclude कर रहे हैं, एक conclusion हमेशा माथे में रखना है कि if I am dealing with non-diabetic kidney disease also having retinopathy, तो वो होता है मैम protein excretion का ratio. If you are dealing with more than 8 grams of protein per day.
Talking about the opposite scenario. What I'm trying to say is you will not seeing that patients, right?
So
by the time they're going to you, they already have.
Yeah, what happens is if a patient has, suppose you include retinopathy and diabetic kidney disease. So if patient has kidney disease and has history of diabetes, but does not have retinopathy, does not have proteinuria. So that is known as non-proteinuric diabetic kidney disease. That is approximately 20% of all diabetic kidney disease patients. If you biopsy these patients. Now, if you look at retinopathy, if a patient has classical diabetic retinopathy, so it is almost certain that that patient will have nephropathy, and we do not do biopsy in this patient. We do not know actually whether this patient has a diabetic nephropathy or not, because the guidelines say that we should not biopsy these patients because they will be having some sort of diabetic nephropathy until and unless there are some outliers like very massive proteinuria, or they have very active sediments, or RBC casts, or the progression is quite rapid. Only in those cases we do a biopsy. But when they do not have retinopathy, or they are not falling into the classical diabetic nephropathy, even if we do biopsy in these patients, 25% of them will have non-diabetic kidney disease and 75% will have diabetic kidney disease. So that is the correlation with all those things. So probably that will probably summarize what you want to ask.
Absolutely right. The thing is that now one interesting point is that where the MRA, steroidal MRA is a drug group of drugs which is meant for the heart failure. But here in this trial, categorically they have kept heart failure as an exclusion criteria. That is most interesting thing here. And probably, I think, because if you really go into the detail of the drug, you'll find that finerenone is a bulky drug, which has got a derived from this. And the two major problems with a steroidal MRA is one is gynecomastia and another is hyperkalemia. These gynecomastia and hyperkalemia are the problems with the aldosterone and as well as eplerenone. So the scientists try to evolve a drug which are not having these two problems. One is no gynecomastia and the no hyperkalemia, but I think they were not very sure about whether these drug will help in heart failure or not. Probably to keep this aside, they kept the heart failure as an exclusion criteria. But interestingly, this drug is also satisfying the criteria of the MRA, which is a steroidal MRA, where you'll see that when the Figaro trial started, if you carefully look at the Figaro trial, you'll see within the 1 month of this starting the drug, where most of the time renal outcome you'll see after 1 year, here you'll see both the curves started separating in the very early part. And in fact, this is the part where you'll find that the cardiovascular outcome is very, very important. And it has proved that this is probably due to the reductions of the heart failure.
So there is, I was telling in the presentation also about this, because the FDA approval on Finerenone was given that the Finerenone is an entirely new group of drug. It does not belong to the MRA subgroup of drugs, because it is a non-steroidal MRA, which is placed entirely differently. So the reason for not including spironolactone in this trial, especially the HF-ref trial, because where according to the guidelines of the ACC, we are supposed to prescribe spironolactone in this patient because it is a class 1A recommendation for spironolactone. So these patients cannot be included in this trial and not be given spironolactone, because that would again go against the guidelines. So that was the main reason why the FF patients were excluded from this trial. So I think
I think the scientists on the investigators were very sure about the kidney outcome, but they are not very sure of the cardiovascular outcome. So the cardiovascular outcome, first they have conducted the Fidelio trial, where there is definite cardiovascular renal outcome is very good. And when they found in the secondary endpoint, they found that they started then use the Fidelio.
There was one more phase 2 trial before they conducted the phase. These are all phase 3 trials.
Phase 3 trials.
So the ARMS trial had 3 or 4 arms in that. One of them was ARMS HF trial, where there was heart failure trial. So there it was a small 900 sort of patients were using this trial. There was a run-in phase 2 trial. There they found benefit in both the renal as well as cardiac. And that is why the Bayer went on and invested so much money in conducting this 13,000 odd patients in both the arms. Otherwise, they would have never put money in this trial, because the ARMS trial did show a lot of significant benefit. But again, that was a small phase 2 trial, and they had shown cardiovascular benefits.
Now I'll have to wind it up. It is already 10. We'll go. So the last 2 questions. So one of the panelists, please tell what is the indications of Finerenone. Where your opinion, Dr. Devnath, where your opinion to start the Finerenone?
First thing, as we have seen inclusion criteria, increasing albumin creatinine ratio, diabetic patient, and declining GFR. Of course, up to the limit of in trials used up to 25 eGFR. In these patients, sometimes we are not able to use SGLT2 inhibitor. Suppose patient has a history of recurrent UTI, patient has some obstructive uropathy. In these patients, I think we can try this Finerenone. In this patient,
In obstructive uropathy?
No.
Not.
What I am saying, we have options SGLT2. Sometimes we are not able to use SGLT2 because patients are on diuretics. There is a chance of acute kidney injury.
Certainly, but the combination of the SGLT2 with a Finerenone has given the best outcome.
Irrespective of use of SGLT2 inhibitor,
We can
Finerenone
use
has
Finerenone,
benefit. Without we are using SGLT2 inhibitor or not.
Say for example, if the patient has gotten a proteinuria of 2.3 gram per day, would you start it?
According to criteria, we have to patient should be on maximum tolerated dose of SERB. If it's not
In fact,
controlling,
this is also very important point to note that all the patients has got 99.5% the patients were on AC inhibitor or ARB. So therefore,
So were they all hypertensive?
not necessary.
So even
50% are
diabetic proteinuria in the absence of hypertension, maximum tolerated doses of ARB? Is that what is recommended?
Yes,
Yes.
yes.
So what is happening to the BP then? So
No, no.
patient is not hypertensive, patient is a diabetic, has
So
albuminuria.
maximum tolerated dose of
Tolerated in
ARB.
terms of BP.
I
So
mean,
how,
if
how much do
patient
they
is-
usually tolerate?
No, if suppose telmisartan, if patient is normotensive, we can give up to 40 milligram. Patients usually tolerates.
Sometimes,
For proteinuria, we have to give ARV if the or AS inhibitor, whatever. So obviously, if the
No,
patient.
we are putting, but maximum tolerated is the word that I wanted to
Yeah,
understand.
maximum tolerated, because most of these patients, if patient is having diabetic kidney disease, in practice, most of these patients are having
Have
hypertension in along with diabetes. Most, if you see the diabetic nephropathy, the natural
When
history
you're saying
itself.
maximum tolerated dose of ARBs,
Yeah.
ARBs,
Yes.
what are you basically looking at? Hyperkalemia and BP. Are you looking at something else?
BP and obviously hyperkalemia. So
These are
we-
the two things that you're basically looking for. And if they're tolerating that,
Hmm.
up to the maximum tolerated dose, you first put the patient on.
Yeah.
Doesn't improve things, then you add on a
Then-
Finrinol?
Yeah, then we add prendinon.
What happens
I-
if you add it at a go? Patient comes to me, albuminuria, diabetic, say hypertensive. What happens if I start telmisartan and Finrinon together?
No,
not
not
together.
together, not
First
together.
line is ACRB.
So you have to put the patient on
No, but
ARBs for how long before you decide on to about
No, we
adding the
can
Finrinon?
start together also. I mean, there is no contraindication as such.
No,
Contraindication.
but the
Like-
trial,
not like-
trial has not
Trial
shown
doesn't
Sir, but
that
not
you start the-
like ARNI, where we have to stop and then we have to start. In these patients, we can start together, though in the
So good,
trial.
because these are the patients who
patients
come
were
to us,
already
right?
on ACE inhibitor or ARB.
No, no, actually, you cannot assess from the very first day, which is the maximum tolerated dose of a patient. That is the most important
Exactly.
thing. So that's why.
So is there a period of time where you see, wait, observe,
Yes,
and then
yes.
you add on?
At
What is that
least
period of
wait
time?
for 4 weeks to see it is the mechanism. So responding to your comment, if you carefully look in the HOPE trial, you will see in the HOPE trial, the average dose of ramipril was 10 milligram. And 10 milligram ramipril they started, and they recorded the reductions of the systolic blood pressure is 4 millimeter mercury and the diastolic blood pressure is 2 millimeter.
But is that what you see
Then
in
in-
practice?
Yes, yes. So that is the thing.
I'm saying, is that what you're doing in practice, practically speaking? Are you starting with 10 milligram ramipril? You have given my patient, because the patient was
We
already on 5, you increased to
No,
10.
we don't start with 10
Yes.
milligram.
That's what I'm
obviously.
saying, but we don't
with
start with
lower
10
dose.
milligram.
No, no,
Say,
no, certainly we start that. word.
but we
Just I
can
am
up
talking
titrate
about
up to 10 milligram.
that
That is-
That is
doesn't
practically
mean-
not happening. What I'm trying to say, what I'm trying to understand is the gap. You know, we all know maximum tolerated doses. You maybe go up to maximum tolerated doses, or cardiologists do, but in all practicality, we always do not. Not all, sometimes we do, but just in terms of albuminuria not getting reduced, if the BP is well controlled, say on 40 milligram telmisartan, I would generally not up titrate it to 80 milligram. Do you do it?
In nephrotic syndrome patients.
No, not
sometimes-
nephrotic syndrome, not nephrotic syndrome. Say ACR is 800.
Yeah.
And then first visit ACR 800, I put the patient on telmisartan 40. Next visit ACR is still 800 or 850 or 900. BP is
Actually,
normal.
most of the
Will I
time
up
we
titrate the
cannot rely on
antihypertensive?
the ACR report actually. If the lab is different.
No, it's my lab. I'll take it to be correct. So, but then will I up titrate the dose of the telmisartan then?
Yes, yes.
Do you do it?
We increase.
Yes, we.
Even if the BP is well maintained?
Yes.
Just because
yes.
the albuminuria is not coming down, you increase the dose of the ARB to the highest tolerated dose. Because that is something we generally do not do. It may be there, yeah. That's all right, if it doesn't fall down.
BFR is not the concern.
So
Okay.
the answer of this question comes from the IDNT and the renal trial, because when losartan and irbesartan were used in both the trials, many of these patients were not hypertensive to start with. They had normal blood pressure, and they were given with low dose of these drugs and titrated up to whether it was tolerated or not. And in both these arms, the benefit was independent of the control of blood pressure. So that is the thing. That is why
So
we
that's
give
interesting.
ARBs inhibitors in proteinuric diabetic patients, but that benefit might not be extrapolated to patients who do not have CKD. That is why the guidelines do not recommend only ACE inhibitors as the first line therapy in non-proteinuric hypertensive diabetic kidney patients. That's why CCBs and ARBs and thiazide diuretics almost come in the same category. But once they have proteinuria, ACE inhibitors and ARBs comes to the first
Number
group of
one.
drugs. So that is the reason why it is like that.
If I am not being criticized, so one AC inhibitor was there, no ARB was there in nephrotic syndrome. I must quote the name, Professor Mani from.
Yes,
He told me
absolutely
if the pressure comes down, give some indomethacin, the patient will come up. But you go on increasing AC inhibitor.
And Dr.
That-
Mani used to use the 300 milligram of
AC inhibitor.
losartan.
Mani used to use the combination of ACE inhibitor and ARB. I have
is-
seen his
that-
prescriptions.
That is before the on-target.
On target prior.
Before the on-target trial, we used to use it, but after that, none is using.
Sir, actually,
I also used it, but everyone that.
sir,
has-
actually, Mani sir is my professor and I know his instinct. He does trial seeing the like apna India ka fate. Like, he knows that every patient is poor or isse acha koi poorest control hai nahi. So he kept always in his
So
mind ki
this is-
to treat poorer, you have to go on titrate increase the dose of ACE.
My last question is that usually the dictum is that you start the 10 milligram, phenonon, and then gradually you are up titrated to 20 milligram. As by the end of 4 weeks, or 6 weeks, you can end up to the 20 milligram. Now, what is your experience, Dr. Ajit, in regarding use? How frequently you get a hyperkalemia?
I have just used this product in 3 of my patients. In one patient, I got severe hyperkalemia, but the reason was different. I want to say the audience also, just check the medicine list by the other your colleagues. So I prescribed this 10 milligram of phenonon, and the cardiologist, he already, he didn't saw my prescription and put the patient on Plenap. And the patient after 15 days came with 6.4 potassium. So it's very important that you have to check the medicine list of the patient. Patient is already on aldactone or ipninone or not. So we have to stop it first.
This is the problem of the different specialties prescribing different.
So we have to
And they
check
are
it.
done to
And
edit it.
yeah, and the other 2 patients, they are not having hyperkalemia, but the effect is still, we have very less experience, and it will take some time to
And-
see how it's going to help us.
And the standard dictum is that you have to keep the potassium level less than 4.8
4.5.
millimole. And when it is 5, then you can go ahead, but always before you should not allow beyond 5.5.
And drug interaction, that is again important. So like patients on the
So how
itraconazole
frequently you monitor potassium if the patient you start a phenonon?
it's
Say,
like
for example, the patient is not on other say on ACRB, certainly, but not other offending drugs.
yeah, it's like by visit as per his kidney function test. Usually, suppose mild to moderate renal dysfunction, and we have started. So once in a month we can monitor his potassium, or very early CKD. Every 3rd month we can do it.
Dr. Gole,
So
your
I think the day Carendia was launched in Siliguri, that was the first day when I started Carendia, because I read about Fidelio and Figaro. Probably, I think around 100, 150 odd patients probably will be on Carendia right now. And I have by default subconsciously, I have prescribed this drug only to those whose potassium is below 4. But I have not seen any symptomatic hyperkalemia up till now. But we make sure that we give our phone numbers to these patients to get back with potassium after 1 month. At least after a month, they should be checking potassium. And if they have a normal potassium and you are not titrating the drug, then the regular monitoring of CKD can continue. But after a month, you have to check potassium. If you do not check potassium, you should not be prescribing Carendia in these patients, because if they land up in hyperkalemia, which is still possible, then these patients will land in trouble. But I personally haven't seen any symptomatic hyperkalemia in the last at least 3 or 4 months after Carendia was launched.
Yes.
One
My
last question, sir. Any drug interaction?
So might be inhibitors like itraconazole or some drugs are there. So we have not to use in third person.
Those
And-
drugs which are metabolized by liver, cytochrome oxidase inhibitors. So those like itraconazole, ketoconazole, these group drugs they increase the level of this. So now my point is that this is one of the hitch where we should not start these 2 drugs together. Now the problem is that ACE inhibitor or ARB is more notorious to cause an hyperkalemia rather than finerenone. No, so better you see the ACE inhibitor ARB first, whether it is causing hyperkalemia or not, then you decide to put on. My experience is that I have my at least 10, 12 patients are getting Kerandia, where I don't even received one case of hyperkalemia in this case. But the thing is that you have to be very careful. You see, if you see the protocol, how they have checked potassium after 1 month. But the thing is that this is highly supervised sort of trial, but in our practice, I think my suggestion is that you should check the potassium after 2 weeks first to see what is happening. Then after 1 month, then after 3 months. So one check after 2 weeks, I think will save you. Otherwise, if you leave the patient for 1 month, if he doesn't return within 1 month, then really is a problem. And whether you might find that the patient will end up with a hyperkalemia and AV block, and the patient is in dead.
So I think the last one of the comments that I would like to give is that all these trials were done on patients who were on fully optimized doses of RAS blockade in the form of ARBs or inhibitors, but still the benefits that this patient had on cardiovascular outcome and renal outcome were statistically significant, with numbers needed to treat in double digits. So that is not a simple thing for any drug to achieve. And even on the subgroup of patients who are still on the third drug of SGLT2 inhibitors, the Kerandia was still having a benefit more than what these drugs were already giving. So this could extrapolate to the fact that just giving finerenone itself without any RAS blockade or without any SGLT2 inhibitors will be useful in these patients, because that is how we can extrapolate from these findings. Because
one point, Dr. Gole, that it doesn't reduce much of intraglomerular pressure.
Yes.
So therefore, the
predominantly,
main intraglomerular pressure is the main pathophysiological problem in diabetes, which you have to address at any way.
That's
so
pillars
ACE
of-
inhibitor and ARB is the first, and along with the finerenone.
Still ACE inhibitor ARB are first, because intraglomerular hypertension has been the main pathophysiology initially, and then
So I think this is the right
acting on-
time to conclude.
At the end of the day, one from internist, Dr. Shekhar, from the internist, what is the message I should carry? My patient with dilated cardiomyopathy, patient is not epinephrine, and he is otherwise keeping well, and he is living CKD in a GAGFR of 45. Should I change from epinephrine to finerenone?
So what is your opinion? Patient is a diabetic, dilated cardiomyopathy. Patient is diabetic.
Cardiomyopathy, and he is having CKD, and she is having CKD.
CKD and diabetic. Patient is diabetic.
Patient is
Sir,
diabetic. and
CKD, which stage? I mean,
stage, she is having something around 40.
GFR.
EGFR is 40.
So as it was discussed, I mean, both having similar effect.
Taking the cost in consideration. She is not.
So epinephrine, it's is like a better choice in patient having heart failure. So I think that should be continued with in place of switching over to finerenone.
In fact, Dr. Ajit Singh is quite right, because these criteria, which the attributes or the property which is finerenone is having, this property is also having the epinephrine. It has also the same property, but the advantage of the finerenone is that it has been studied as an anti-inflammatory and anti-fibrotic drug. So therefore, you can jolly well continue with the epinephrine. No problem.
Sir, actually, like this discussion was happening in a lot of countries, part of countries. So I can assure you, sir, till that nephrology will exist, I think these two drugs, one is finerenone and other one is that HIF inhibitor, जो हम लोग anemia में दे रहे हैं. I think these two drugs is gonna persist till the planet is gonna evolve, sir. So this is the thing.
Thank you, all the panelists, Dr. Gole, Dr. Gaurav, Dr. Ajit, Dr. Avinav, and Dr. Sanjeev Pandit. All, thank you very much for your participation and a nice discussion. And thank you all the audience for participating for this program. Thank you.
Thank you, Dr. Shekhar Chakraborty. I mean, the powerhouse of knowledge. I've been continuing this program so long. Thank you so much. Thank you to chairpersons, panelists, the stalwarts of nephrology, Dr. Vishal Gole, Ajit Singh, Dr. Vivek, Dr. Abhinav, and Dr. Sanjeet, and also Dr. Shapan Kumar Roy, who is there, actively participating, Dr. Sudeep Nath, Dr. Ashish Nandi, Dr. Mrityunjay is there, Dr. Bhushan, and at last, Dr. Arundhati. For participating and continuing this program for so long. At last, I'd like to thank from Bayer, Mankind, and from Sanofi for the logistical support. Thank you so much. It has been really a wonderful program.